Let's see. Okay, well, let's get started so we don't chase time today now. Okay. Okay. Okay, you want to get started with the introduction like yesterday? Okay. Okay.
Hello, everyone. Good morning to you. Greetings from the island of Bielsa again. Okay, welcome to day 2 of this endovascular conference. A special thanks to everyone who's joined in or who joined in yesterday, day 1, virtually in person. Special thanks to you for taking out time to come gain more knowledge to help you improve the healthcare system in Nigeria and, of course, across Africa. You would agree with me if you were in attendance yesterday that this has been eye-opening, highly impactful, and insightful. And if you think that was it, then get ready for more, because day 2 is even going to be more, impactful. So I'm going to enjoin you to sit back, relax, and get ready to learn more about endovascular care and how we can improve healthcare delivery in Africa. Thank you very much as you do participate. And if you've got your colleagues, your friends, your associates, get them in here, let them also hear what we have to talk about. So at this point, I'm going to be handing over to Dr. Oye right there in Lagos, and wish all of us a very happy and insightful learning session. Thank you.
Thank you, Cynthia. Welcome again to day 2 of our conference, the 5th annual Endovascular Solutions Conference for Africa. This is supposed to be a practical learning, pragmatic conference for attendees. We hope that you'll learn, as Cynthia has indicated, a few tips of the trade and to increase your endovascular knowledge and judgment. And we plan on continuing today with more exciting topics, which I feel you'll find fascinating. The 5th annual endovascular conference, as stated, will address the dissemination of endovascular treatment options with a focus on fundamentals of endovascular surgery, necessary judgment, and patient selection criteria. Discussions will include inherent challenges of making endovascular surgery feasible in Africa. And I'll conclude the evening by giving a few words on that topic. Faculty of well-respected clinicians and medical students in training to become physicians will give us exciting topics today, from simple to complex, as we move on to day 2. We will begin our talks today with Dr. Emmanuel Edafe, who is a respected interventional cardiologist here in Nigeria. He had his training in India and has been quite active in the cardiovascular, perivascular scene in Nigeria. Dr. Edafe is quite adept in management of cardiovascular problems, and is a consultant for the Bielsa Special Hospital also. He's done many pacemaker cases here in Bielsa, and we're excited that he has the opportunity to present today 2 exciting topics. Dr. Edafe will begin the ball rolling this morning. Thank you, Dr. Edafe. Welcome.
Can you see the slides?
Yes.
As I'm moving in, can you see it, sir?
Yes.
Very good. So Thank you, Dr. Oye, for the kind introduction. It's a great time to be with you again. I've learned so much from you, and working with you at the Bayelsa Specialist Hospital. You are really a great a vascular surgeon, and I've learned so much skill from you. Thank you again for the transfer of skills in working with you. So today we talked about two cases of May-Thurner syndrome. I have no conflict of interest in this presentation. May-Thurner syndrome, that is iliac vein compression syndrome, is caused when an anatomical variance of the left common iliac vein with lateral or anterior spall is compressed by the right iliac artery, resulting in thrombosis of the vein. It can present as left deep vein thrombosis, which can lead to pulmonary embolism or chronic changes of venous insufficiency in the lower limb. So the first case is a 36-year-old Nigerian female, multi-para, was admitted to a Dubai hospital in January 16, 2020 for left lower limb pain and swelling. The CT scan done in that hospital in Dubai showed that she had extensive thrombosis along the popliteal, the superficial, and the common femoral, extending into the common iliac vein with a compression of the so this refused intervention. Because she refused intervention, she was put on anticoagulation. There are other tests that were also done, including factor C, protein C, protein S, and they were all normal. So the progress was that the patient was probably properly anticoagulated with Xerato, and 2 years along the line, she presented to us. That was about 3 months ago, and we repeated the CT and also showed this same thing. So what we did was that went in. So we went in. We took a consent. Then after that, we then also cannulated the vein as seen here. Then after that, we did a simultaneous injection into the artery of natural white vein flowing up to see where the point of occlusion is. And this is what we saw. I hope the video will play. I hope they will play. Yeah, so this is the point where we have the occlusion, where we have the point of compression. So what we did at that point was to pass, we took our it measured 6 by 80. And
Dr. Edafe, we cannot see the picture. Dr. Edafe. Dr. Edafe, we cannot see the picture yet. Your images. We're not seeing the images.
You don't see pictures?
No, we're not seeing the images right now.
Let me go.
Go back a couple of slides, yeah.
I can see. Can you see now?
Just an empty slide.
Can you see this?
No.
Let me go back again. Can you see this?
It's not moving. No, but you have a static slide. It's not moving.
Can you see this?
We don't see anything at all. With the slides there, but it's not showing. Click on the slides. You move click on the slides.
I think you need to share it again, sir.
You need to share it again, maybe.
Okay. Yeah. So let me share again. Okay. Okay. Can you see my slides now?
Not yet, sir. Yeah, you can see your slide now.
Okay. Can you see the pictures now, sir?
Try moving the slides now. Yeah, it's visible now.
Okay. Okay. So of the narrowing, then also because of the chronic DVT, the vein has recannulated. Those are the things that we saw. So the first thing we did was to pass the self-expanding stent 6 by 80 millimeter. Then after that, we post-dilated the self-expanding stent. Yeah. Yeah, so this is the post-dilatation going on the self-expanding stent. And the results were satisfactory. The patient was stable post-procedure, and the patient was discharged home the following day. We put him on Xerato for about a month. The leg swelling has resolved, and she has been on follow-up with us at the outpatient clinic. The second case was a 48-year-old female with massive lower limb. From the background, I don't know, the technical should do something on that. A 48-year-old female with massive left lower limb DVT from a compression of the iliac vein from 36 weeks uterine fibroid. She was being anticoagulated with subcutaneous 80 milligrams twice daily, but despite the anticoagulation, she developed a submassive embolism with a big right to put an IVC filter, continue the anticoagulation, then also keep in view for us to thrombolize this patient because of the right atrial clot. Can you see? Can you hear? My slide just disappeared. Can I reshare again? So the plan was for the surgical sclerotomy at the same time when the ONG team will take the hysterectomy. So the IVC filter was already in place, and what we are planning is for the hysterectomy and Fogarty catheter embolectomy when the patient is relatively stable. So it's compression of the vein by the overlying right common iliac artery, and the significance of the compression. So this is anatomy of the vein. When the right iliac artery compresses on the left iliac vein, you have a situation we call May-Thurner syndrome. So MTS most frequently present as a chronic venous insufficiency in young to middle-aged female, and is present in about 18 to 49% of cases of lower limb deep venous thrombosis. As chronic venous insufficiency referred to a state of venous hypertension in the lower extremity that can lead to a spectrum of pathology ranging from swelling and pain to skin changes such as hyperpigmentation and ulceration. The presence of MTS is suggested by history of recurrent Auntie Cynthia. Is okay. Okay, I think I don't have another device. So. But I'm hearing background noise. Okay, I think it's reduced now. Oh. So the presence of MTS is suggested by a history of recurrent lower vein extremity DVT with symptoms associated with chronic venous hypertension, lower limb swelling, and ulcers. The MTS secondary to extra weight of the fetus and increase in time spent on supine is postulated to explain about 80% of DVT that occur to have shown to occur in the left lower limb. So MTS originally was based on the gross anatomy finding, but MTS today most time is diagnosed on imaging. Now the first image evaluation of MTS is the Doppler ultrasound. Now if the Doppler ultrasound finding is not conclusive, then we can go for a CT or I don't know where this background noise is.
It's the Port Harcourt noise, I don't know.
So we can go for a CT. So the importance of MTS in patients who have no other obvious reason for hypercoagulability and also present with left vein thrombosis. So to rule out this, we must do the inherited factors like protein C, protein S, and factor V. So people with MCS may have recurrent surgery, pregnancy, or on oral anticoagulations or immobility. So, but the management of MTS may require medical and surgical. The medical management we deal with anticoagulation, sometimes catheter-directed thrombolysis, percutaneous stenting, which was done for this patient, and embolectomy. Surgical management may also include
Hello, sir.
Hello, can you hear me? I don't know where this noise is coming from.
Now we can hear you properly now. Please share your slide again.
Okay. Sorry for this noise that we are getting. I don't know the source. Just give me a few minutes. Let me upload the slides. Just few minutes. Let me upload the slide because I'm almost getting to the end of the discussion before. Can you see the slide now?
Not yet. Yes. Yes.
Good. So I said that management of MTS include medical and surgical. The medical thrombolytic therapy or percutaneous stent placement and embolectomy depend on what strategy or what is available at the center where the patient presents. The surgical management will include also thoracic catheter embolectomy or a graft. These are some of the options that may be available for a patient with MTS. So in addition to the stenting and increasing burden of the clot burden distal to the point of compression may require auxiliary methods such as the catheter-directed thrombolytic therapy and percutaneous mechanical thrombectomy. Now, some practitioners may also suggest the use of IVC filter to prevent possible fetal pulmonary embolism. Like this second case I presented, I talked about this patient having 36 weeks uterine fibroid, and there is a compression on the left iliac because of the compression of the 36 week fibroid. The left iliac artery is compressing. Right iliac artery is compressing on the left iliac vein, and now the patient developed a very extensive deep venous thrombosis. And as the plan we had initially was to put an IVC filter, then the patient go for hysterectomy. At the point of hysterectomy, the catheter, thoracic catheter is being used to take out the clot, and whatever that may migrate, the catheter may help to prevent further embolism of such clot towards the pulmonary artery. But unfortunately, before hours before the surgery, the patient threw a pulmonary embolism and the surgery was suspended. So we have to put the IVC filter, see how we stabilize the patient. Then we'll now move back to the strategy that we have. That was the second case I discussed. So severe May-Thurner syndrome may require thrombolysis if there is a recent onset of thrombosis. But one of the things again here is that if a patient has a very extensive DVT, if you give systemic thrombosis, it will not work. Except either you do a catheter directed or you do embolectomy. That is where you'll be able to get something out and significantly reduce the burden of that disease for the patient. Stent may be used to support the area from compression, and that is the angioplasty. So in conclusion, May-Thurner, the MTS is a thrombosis of the left iliac vein due to a compression from the right iliac artery against the fifth lumbar vertebrae. It should be considered as a differential diagnosis in patients with unilateral left lower limb DVT. So it presents at left DVT and changes over time due to venous insufficiency. So these are some of my references. Thank you very much.
Thank you. Thank you, Dr. Edafe.
Yeah.
Any questions from the crowd here or virtually at this time? Dr. Edafe, my question to you would be, what forms of thrombolytic devices do you have, embolectomy devices do you have? Percutaneous status.
Good. Good, sir. Good, sir. Here in Nigeria, what we can do here is the catheter, Fogate catheter. I work with the surgeon, Dr. Shelley. The next presentation I will take, I will show some of the things we did in Bayelsa with Dr. Shelley. So Dr. Shelley helped us in exposing the vein or the artery. Then in making we take the Fogate catheters and we take out the clot. That is very much available here. And that is also a strategy that we are using for this second patient, or we are planning for the second patient I presented in this talk. Then second thing is that we also have the capability of doing the catheter-directed thrombolytic therapy by just percutaneously we puncture the vein. Then we make multiple holes locally, just on it, 3.5 or 4 French catheter. We pass it, then we run the thrombolytic therapy for almost 12 hours. 8 to 12 hours. Give it via popliteal access. We have also done it via the femoral access, and that works very well for us here. Then the other ones like the angiojet, we don't have it here. So these are the tools that we have. Then systemic thrombolytic therapy. These are the 3 strategies that we have here in the country. Every other strategies, the instruments are not available with us, sir.
Okay, very well.
Well done.
Thank you, Dr. Edafe. What do you use for your thrombolytic agent? And that's available.
Excellent, excellent. Here we use we have Artilase. Most time we use Artilase, and if Artilase is not available, we still go for tenecteplase. We have tenecteplase, we have Artilase. Artilase is around 600 and either 95, roughly 700,000 naira. Then tenecteplase from the drug rep is roughly around 650,000 naira, similar to Artilase. Then if the patient can afford, we go for that. But if that's possible, then we have no options than to go for our unselective streptokinase, which we also manage we get it sometimes 30,000 naira, 40,000 naira. We're able to get streptokinase.
Very good. We'll talk to you some more about the options that you have for therapy here later on. We'll have later on this afternoon, Dr. Papa will be giving a talk on pulmonary embolism, and she has quite an interesting talk, and she's the director of vascular services at New York upstate, sunny upstate. So we'll hopefully enjoy that talk, and I think you'll see some of the other structures we use also. Okay, and I'll make some comments at that time. Okay, so let's reserve our talk with you to a second talk in a second. Let's just go ahead and you get your computer situated right now. We'll go to Senegal and talk with Dr. Papa and see if he can give us a talk, and we'll come back to you. Okay, thank you.
Yes, sir. Thank you.
Yeah, we call you. Yeah, I'm gonna call you back. Ready? So our next speaker coming up from Dakar, Senegal is Dr. Papa Dieng. He's an endovascular vascular surgeon who trained both in Africa as well as in the United States. He trained under the great Dr. Edward B. Dietrich, and will be sharing with us his experiences in Dakar. Dr. Papa on angioplasty stenting for renal stenosis.
Hello.
Hello, Dr. Papa. Hi. Hello.
Hi, Dr. Oye. How are you doing?
I'm fantastic. How are you?
I'm good too. Thank you.
Good. Hope you're doing well in Senegal. Yeah.
Yeah, doing good.
Good. All right. We're looking forward to your talk. I guess on angioplasty stenting for renal stenosis. Yeah.
Yes, yes.
Okay. The floor is yours. Thank you so much.
Hello,
Yeah,
everybody.
go ahead. Yeah, go ahead.
Okay, good morning, audience. I'm so glad to present my work about angioplasty stenting for renal artery stenosis in Dakar, Senegal. Atheromatical renovascular diseases are widely more frequent in the last decade. Vascular risk factors can induce an artery wall plaque. Percutaneous transluminal angioplasty of the renal artery has become an increasingly widespread peripheral vascular intervention for the treatment of renovascular hypertension. High blood pressure that does not respond to common drug treatment, the loss of kidney function or acute renal failure, chronic kidney disease, and fluid retention. Revascularization of renal artery is sometimes needed. So the indication for revascularization are resistant hypertension, progressive renal insufficiency with salvageable kidney, circulatory congestion, recurrent flash pulmonary edema, refractory conditions, heart failure. To do such procedure, we undergo local anesthesia, which is enough. Then with a small nick, we can introduce devices, balloon go along the wire into the narrowed kidney artery. Then the balloon is inflated and narrowing is gradually widening. The stents go to the wire and is deployed. In this video, you can see a proximal stenosis of the renal artery. After injection of dye, you can see the small flow to the kidney. The flow is small to the kidney. In this image, you can see,
We cannot see Dr.Papa. We cannot see the video.
Oh. You're not seeing?
Not yet.
We share.
Can you share it?
If you click a button beside the microphone, there's a square with a arrow going up. And then it'll prompt you to share your screen. Were you able to see it, Doctor?
Yeah. Can you see the image? No?
Not yet. Not yet.
Not yet.
Oh, man. Sorry. So looks like it's not working.
Did you click that square and then click your desktop? The square with an arrow going upwards beside the mic symbol?
Beside the mic symbol.
It's camera, mic, and then open share tray. Once you click that, you click desktop window and then click OK or share.
That's it. Got it.
Yeah, got it.
You got it, Dr.Papa. Go ahead.
We can see it now. Thank you.
Oh, okay. So in this video, you can see a proximal stenosis of the renal artery. And after injection of dye, we have a small flow to the kidney, just a small flow to the kidney. Then we dilate with a 3 French balloon. After that, you can see the stent in and the flow to the kidney is much better without stenosis. We put a 3 millimeter stent that gives us a very good flow to the left kidney. In 2017, we published our inaugural experience in the vascularization of renal artery in Annals of Cardiovascular Disease. In this study, you can see on top and right a proximal stenosis of the left renal artery. And then below, you can see the stent fully deployed. Since that day, we have more patients, and now we did 24 cases. All cases are narrowing at least of 50% stenosis. Most of the patients are old with atherosclerotic renovascular disease. In our patient, we have 6 Takayasu disease. They were young patients under 24, After the procedure, we keep patient overnight and discharge them in the morning after the procedure. They receive 3 months of clopidogrel and lifelong aspirin. Here you can see with the CT scan after procedure in the right renal artery, the stent fully deployed and a good flow to the kidney. This procedure have some risk. We can occur bruising, bleeding on the site, damage to the renal artery by dissection, for example. We can have after procedure blood clots, allergic reaction to the dye during the procedure, or stent misplacement. Also, we can have kidney failure. In the literacy for evaluation of the results, authors assess that estimate glomerular filtration rate increase significantly compared with baseline. Also, blood pressure significantly decreased compared to baseline. And we have less hypertensive medication taken. In our discussion, for renal endovascular revascularization, most frequent indications are refractory hypertension or progressive renal insufficiency. This intervention is most often done to mitigate either or both problems and will rarely cure either. Revascularization remains controversial. We've published data that both encourage its utility. The issue of renal angioplasty is very controversial, with skeptics noting that despite over 30 years of experience since the inception, available data do not demonstrate unequivocal benefit compared with medical management. In our study, we found that we have beneficial effect on blood pressure control. Also, we have better control with less medication. In conclusion, recent data show benefit of renal angioplasty for blood pressure and glomerular filtration rate. The use of filter protection seems to be accurate. Any hypertension that is resistant to the conventional treatment should be regarded as an alert to look for a secondary cause such as stenosis of the renal artery. Where endovascular approach has been used, such as in Senegal, the results are encouraging. Thank you for your attention.
Thank you, Dr. Papa. Nice talk, Dr. Papa. Any questions from the audience before we ask them?
Thank you, Dr. Papa.
Dr. Papa, you did mention stenting. What size stent did you put? Again, I wasn't sure if I heard 3 millimeter or what. What on your stent did you put it in on the case you presented?
We use 3 millimeter balloon stent, balloon expandable stent, 3 millimeter balloon expandable stent.
Any particular reason why you used 3 millimeters and nothing bigger than that?
Yeah, because most of the time we have, small renal arteries, so we think that 3 millimeter is more effective for such arteries. Sometimes we use, in one case, I think we use 4 millimeter stent.
What's your technique for passing the the wire and the catheter to the renal artery to engage the renal artery, what support catheter do you use?
I'm going to call you, eh?
Yeah, we use a long sheet, will come above the renal artery. Then we most of the time use GB2 catheter, going over the wire.
What's your favorite wire for the renal artery intervention? 035, 014, 018. What's your working wire?
Yeah, we're using 1.4 wire.
Okay, very well. Thank you so much. Yeah, there's a question. There's a question here.
I
There's a
think I
question
have
for
a
you.
question.
Okay, go ahead.
Yes. Dr. Papa, thank you very much for your presentation and your work.
Thank you.
Number one question is, I noticed if the slides you were showing, you came from the femoral access. Is there any strategy that will make you take the renal stenting from either a brachial or a radial access? What are your experience on that? Then the second question is that do you use FFR for lesions, or you just use angiographic assessment of these lesions, then you move ahead with them?
Yes, thank you. Thank you. Yeah, for the access, I always use the femoral access because I was trained to do this access. I never did radial or things like that to go to the artery. Yeah, for images, we use CT scan and angiography to see the lesion and to manage the size of balloon or center we're gonna use.
Okay,
Thank you,
because
Doc. Go ahead,
what I'm asking is, if you look at the trials on renal artery denervation with hypertension, we have not actually seen overwhelming results so far. And but the report you gave here so far shows that once the stenting is done, most of these patients, their BP, the control of their hypertension is better, the profiling is better. So I want to know also, how long have you followed them up? Then the second question that also follow, there are patients that may have congenital renal artery stenosis. Do you have experience in that? And then maybe Dr. Oye may also throw some light on congenital renal artery stenosis. What are your strategy for such cases?
Oh, okay, thank you. So we start doing renal angioplasty since 2017. So the follow-up is about 5 years. Yeah, for the first patient, I think, which is not so bad. We follow the patient after procedure by measuring the blood pressure. Yeah, the blood pressure is, a good way to see if the procedure give a good result. And for that, yeah, we have a good result. Also, we can check about patency using ultrasound or CT scan. We don't have experience doing renal revascularization for congenital disease. Thank you.
Thank you very much for the good work you are doing in Africa.
Oh, thank you so much.
Yeah.
Thank you, Dr. Papa. I appreciate it.
Oh, thank you.
Our next speaker will be coming from Beckley, West Virginia. and they'll be giving us a couple of case studies if we can get them in. That would be John Evans and Nabila Ahmed. First, John will be talking about management of aortic arch and upper extremity thrombosis, and he has the floor. John is a medical student that works with me in Beckley, West Virginia. John, go ahead.
Hi, Doctor. Can
Go ahead.
you hear me?
Yes.
Okay. Just give me 1 second. Okay. So hello, everybody. My name is Jonathan Evans. I'm a medical student with Dr. Oye. It's a pleasure to be here today, and thank you for allowing me to speak with you all. I have a couple case studies about thrombosis of thoracic aortic arch and right upper extremity issues. So I just want to go over agenda. I'm just going to introduce the topic, some treatment options, and I have 2 cases and a conclusion. So first, let's introduce the topic. In the absence of trauma, arterial disorders of the upper extremity that require revascularization are based off of symptoms of acute or chronic ischemia. Typically, arterial disorders of the upper extremity are less common than lower extremity, and acute disease is more common than chronic issues. Diseases should be confirmed with non-invasive upper extremity studies such as risk brachial indexes, computer like CT angiography, digital subtraction arteriography, and if there are things like cerebral symptoms, you can also include chest and neck CT angiograms and duplex ultrasounds for the carotids. So a couple examples here is the risk brachial index, where you take pressure at multiple points between the brachial and the wrist, and then you divide them over each other and see if they're less than 1 or anything above or anything less than 0.9 means that there's an issue. And here in this example, we have their left hand is 0.69. So there's an issue with circulation here. On the CT angiogram, you can see an area of aneurysm and stenosis back here. And then this digital subtraction angiography of a hand, you can see that there's issue distally with arterial supply. Some causes and indications for treatment, and the most common ones are upper extremity embolism, traumatic injury to any part of the arm, or atherosclerotic occlusive lesions. Some more uncommon ones are like thoracic outlet syndrome, upper extremity aneurysm, and you have some disease processes like giant cell arteritis, Takayatsu, and sclerotic arteritis. So what are the treatment options? Well, the treatment options vary by cause and location. If it's traumatic injury, the primary way to treat is through arterial repair or venous grafting using autogenous vein. Usually the vein is harvested from an uninjured extremity, and vein bypass may be necessary to manage a more extensive injury. If it's a symptomatic lesion involving the aortic arch, you can do things like an open surgical bypass with angioplasty and stenting. Prosthetic bypass is usually considered the first-line treatment. If you cannot do surgical repair for whatever reason, maybe the person might not be a good candidate for it, you can use angioplasty with stenting. If there's an aneurysm, you can also do stent graft repair as an alternative to open surgery. If it's an ischemic event, if it's acute, you can use catheter-directed thrombolysis depending on the time, or you can do surgical embolectomy. If it's a more chronic issue, they prefer a surgical bypass. And again, you can use an autologous vein for reconstruction. This is just Gore-Tex, which is a brand. It comes in many shapes and sizes. Some have loops to them. some are bifurcated. And then this is an example of what balloon angioplasty is. You have a buildup of cholesterol, you insert a catheter with this balloon and the stent, then you inflate the balloon, which pushes the stent to the walls and keeps the structure open. There's also some adjunctive procedures that may be required depending on the injury. You can have fasciotomy if you suspect compartment syndrome. And when you suspect compartment syndrome in somebody that has systemic hypotension, a crush injury to the arm, or has the combined arterial and venous injury, which causes a ligation of any parts of the circulation. And more extreme, you might have debridement and amputation. If post-op soft tissues do not improve, they may require the debridement. And if they continue to not improve, then you may have to amputate. But recent literature is saying that a wait and see approach is typically preferred to minimize any loss in tissue or limbs. And then here's just an example of a case. This is an R case, but it's from up to date where they had to do fasciotomy of the upper limb. It says this person had severe ischemia of the upper extremity due to an embolus related to AFib. On initial presentation, both sensory and motor deficits were apparent, but following embolectomy to restore the upper extremity, compartment pressures were 80 milligrams of mercury, which necessitated decompressive fasciotomy of the arm and the hand. Afterwards, it says that nearly 1% of the hand function was regained postoperatively. So we were able to save the limb, which is good. So let me present the first case we have here. It was a 64-year-old male who presented to the outpatient clinic with weakness of the right upper extremity, pulselessness, pain, and headache. This person is on several medications for congestive heart failure, coronary artery disease. He's known to be non-compliant. He has severe bilateral carotid stenosis. He's had CVA ×3, diabetes, and he's a recurrent smoker. So he's pretty prone to be having cerebral or vascular disease. We did CT imaging on him, and as you can see here, there's thrombotic occlusion in the right aortic arch, a subclavian artery, an axillary artery, and brachial artery. So what we decided to do is an embolectomy with angioplasty and stenting to prevent limb loss, because when he presented to the clinic, he was in severe pain. There was changing color of his limb, and we sent him immediately to the ER to get him admitted so that we could perform this embolectomy. So it was a simple procedure. There's about 6 steps where you expose the brachial artery, you do the embolectomy, arteriogram, angioplasty, endarterectomy, and then we finished off the procedure by doing a runoff of the right lower image. I'm going to go into more depth of each of these here. So first, we exposed the brachial artery with a 3-centimeter incision in the cubital fossa. I didn't have a picture of the actual event, so I got this little illustration here to show. And then we did an embolectomy with an 11-blade scalpel, a 1-centimeter arterotomy, followed by an embolectomy catheter size 4 inserted into the thoracic aortic arch. You can see it here coming in. Then we did an arteriogram to find the occlusion area. And as you can see here, there's a large area of occlusion in the brachiocephalic and subclavian region. Then we passed an embolectomy catheter, was crossed with a 0.03 glide wire via 6 French sheath, and an 8x40 Dorado balloon was then inflated for 90 seconds for angioplasty. Here you can see the balloon is being inflated. Then the last 2 steps, we did a repeat arteriogram, and you could see the flow had been restored. And no stenting was required at this time. And we also did run off down through the entire arm, where you can see the brachial artery has had flow to. But at the entry port, we did notice that there was residual plaque there that required an endarterectomy, which was just a quick removal of that. And again, after that, we saw complete return of flow. And here's the imaging of what we removed from his arteries. Quite a lot of plaque here. And then there's a video here that I hope works. Showing the of his flow. So extremely successful surgery. We did run into a complication about a month later. He had to have repeat angioplasty with stenting because he was experiencing issues again. And here we basically repeated the same thing where we placed balloon stenting. Well, this time with the ballooning, we added stenting, and then this is post-operation where you can see return of flow. And this is what we removed from the upper part of his arm, where the lower was not too much occlusion. So that was case one. Case two is a more recent one with a patient with innominate artery stenosis. This was a 76-year-old male with innominate artery stenosis, and flow was restored again with balloon angioplasty. This time we used a 9x40 millimeter Dorado balloon and placed a 10x40 Luminex stent. So here you can see the initial CT angiogram of the occlusion. And again, here's a more close-up picture of severe stenosis. Here we're placing the balloon, and these little dots here are showing the stents. And this is post-stenting with return of flow. Okay, so in conclusion, why does it matter? Why am I talking about this today? So endovascular techniques can often lead to limb salvage even after revascularization failure. As we saw in the first case, we had to repeat most of the procedures and place stents, but we were still able to salvage his limb from the initial presenting symptoms and the secondary presenting symptoms. So in general, it's a very good idea to approach these issues this way, because the operative mortality is quite low. It's from 0 to 2%. And when you look at what we're actually doing with placing bypass grafts and conduits and things, you're having 5-year patency rates ranging between 60 and 70%. And the 5-year survival rate afterwards is about 80%. So the major complications aren't that severe. They're mostly brachial plexus and median neuronal nerves that can cause issues down into your arm sensation and possibly movement. But as electric cautery has advanced, we've also made a lot of advancements in minimizing these complications. And here's just some of my references. And again, I'd like to thank you for allowing me to speak, and I'm open to any questions.
Thank you, John. Interesting case. Any questions from the audience? This is a nightmare for the surgeon, where somebody who continues to smoke and won't stop smoking has found out carotid occlusion and right upper complete thrombosis. So I mean, you're between the rock and hard place. And fortunately, we were able to restore flow, and went home and came back again. This time, well, I'm like, just after stent it, I'm not going full round, so we just went and sent it, and that worked for him. The second person who came in with from a referral from a small hospital, he was having cerebral symptoms, and the carotids were normal, and the only significant problem was the high-grade stenosis, as indicated by the speaker. So we're able to do angioplasty and it worked well. And went in and put a stent also, so we did not come back. So those are easy ways to hopefully in your community, when we have simple stents, nothing extraordinary, should be able to do simple stuff that with a four-minute catheter, and take a clot out and put a stent or balloon if you need to. Yeah. All right, thank you, John.
Great job.
Yeah.
Thank you.
You have experience with the efflux thrombosis, superior vein thrombosis, with first stream or ligaments.
Oh, yes, absolutely. Yes, we do. And I really like in those cases, if it's thrombosed, if I can do thrombolytic therapy, I'll do it. Or if it's blood chunk, embolectomy. Nowadays, we have other devices, a device that can remove big chunks of blood. That's quite helpful. Then we follow that up with, I like to use the merciful stent, and that area works very well.
So then you don't have to worry about
About resection. I know, yeah, yes. Okay, our next speaker will be coming to us again from the US, I believe, in the same US still, no? Yeah. And that's Dr. Nabila, is she there? Okay, Nabila. And say, yeah, she's in the same place.
Yes,
Yeah. Yeah, Dr. Nabila
Yes.
Ahmed will be presenting to us. She's one of our young medical students also, and she has an interesting topic. So Nabila, please make it quickly because we have Dr. Piccolo will be coming to us from South Carolina. Thank you so much. You ready?
See her screen, or can you see my screen, Dr. Oye?
No, we can't see anything here. No,
Blank.
it's blank.
Apologies, give me 1 second. Not sharing it from your- I think it's- That's screen recording, not screen share. Oh, here.
Just let him do one that's waiting if we can.
If you'd like to continue, we can.
Okay, well, I'll go with Dr. Carmen Piccolo's case, then we'll come back to you, okay? Well,
Okay, that's-
what kind of your case? Okay, yeah, Dr. Carmen. Carmen, are you there? Sorry. Let's talk about it. Is he on?
Dr. Oye, we got her presentation to work now.
Well, I think Dr. Carmen Piccolo will go first now because of time
Fine.
constraint, and I'll come back to you, okay? If
Okay,
I can get
no
him.
worries.
Just stand by. Don't go too far.
Yeah. We're here.
Hey, Carmen, are you there?
Can you hear me?
Yes, we can hear you.
Okay. Let me see if I can share my screen. I can probably do this.
Beside the microphone button is a box with an up arrow. That's the
Yeah, I got it.
share screen.
I have
Okay.
two different things. That's why. Can you see it now?
Yes, we can, sir.
Okay, perfect. I'm ready whenever you guys are.
Are we good? Can you hear us now?
Yeah, I can hear you. Can you hear me?
Okay, all right. Again, Dr. Carmen Piccolo is from South Carolina, accomplished vascular surgeon, endovascular surgeon, and he will be talking to us today on the management of popliteal aneurysms. Thank you, doctor.
Yeah, thank you. Hope everybody's having a good day. We're going to talk about, again, the management of popliteal artery aneurysms today. I have no disclosures. I will say that the first thing is that if you look at Society of Vascular Surgery and the Journal of Vascular Surgery, and even online and on mobile platforms, there are clinical practice guidelines that can help us decide with treatment of popliteal artery aneurysms. This is a relatively new one actually from this year. Just as a background, as we all know, that popliteal artery aneurysms are the most common peripheral artery aneurysm outside the aorta iliac and the brain. It happens up to about 2.8% of the population. Because it's such a low number in the population, it's not really cost effective for screening everyone in general. Most of the popliteal artery aneurysms occur in men and mostly in the 60s and 70s. As far as, the relationship of popliteal artery aneurysms and AAA, concomitant AAA in patients who have a popliteal artery aneurysm is around 30 to 40%. And having a popliteal artery aneurysm, if you have a AAA, is around 3 to 11%. It's a little bit higher than that on the higher side for men, especially men who have large aneurysms on initial duplex evaluation. So perhaps in men with large aneurysms of the aorta found initially, it may be helpful in screening those patients and those patients only. Anything over 15 millimeters, we really consider an aneurysm, obviously. We always talk about the bilateral nature of popliteal artery aneurysms. The the contralateral popliteal aneurysms are actually more common in asymptomatic patients for whatever reason we see in literature. It happens around 50% of the time. And it really doesn't matter whether you have a unilateral aneurysm and nothing on the other side, or bilateral aneurysms as far as your risk of having limb-threatening ischemia. I think in the remote past, people thought maybe if you had both, it's higher level of disease, maybe a worsening risk of limb-threatening ischemia. That really doesn't bear out in the literature. So because of this, there is the first recommendation from that paper, which is they shouldn't screen, shouldn't screen patients in general. And if you do have one popliteal artery aneurysm, you should screen those patients though for the contralateral side. The growth rate of these aneurysms depends on a bunch of things. The biggest one really is size. A larger aneurysm at diagnosis grows faster. And so those have to be maybe when you're surveilling them looked at a little bit closer. There's a bunch, like I said, a bunch of things that have a higher risk of accelerated growth. Again, the size at initial evaluation is one of the bigger ones. You can see there the odds ratio of 5.5, but also thrombus. So thrombus in the aneurysm itself also has a higher risk. And for whatever reason, patients who have atrial fibrillation, another higher risk of growth. And then if you have this aneurysmosis kind of disease where you have multiple aneurysms, specifically a AAA, that also has a little bit higher risk of growth. You can see here that actually, regardless of the size on initial diagnosis, popliteal artery aneurysms with thrombus grow a lot quicker than those without. As far as their presentation, about 20% of them are completely asymptomatic at the time of diagnosis. We do get some obstructive symptoms, so non-ischemic symptoms where you have some paresthesias or a popliteal mass or some pain in the popliteal fossa. That happens around 11% of the time. We do see patients coming in with intermittent claudication 25% of the time. We see chronic critical limb ischemia at about 11% of the time. And unfortunately, what we see, most is the acute limb ischemia event, which is really a dreadful thing, which we'll talk about in a little bit here. And of course, the larger the aneurysm, the more likely it's symptomatic. And you can kind of see, on that little diagram there that, the larger the aneurysm, not only do you have more symptoms, but more severity of symptoms, especially with acute limb ischemia. And we'll get into that reason for a second as well. And so this just goes over the relationship between the diameter of the aneurysm, excuse me, and the severity of the limb ischemia. And so again, the larger the aneurysm, the higher the chance of you having limb ischemia and having, this limb-threatening state. Not only is size important here in thrombus, but because of the size, you get a distortion in the actual artery. So as we all know, the popliteal artery is a relatively fixed structure on the upper and lower ends. Obviously, as it enlarges, the aneurysm becomes more tortuous and more distorted. And, anything greater than 3 centimeters has a higher risk of distortion. And when you have distortion, of this artery, as you can see in that picture, that's what leads to a significant risk of thrombus and then limb ischemia. And so when looking at patients that come in for either, thrombosed aneurysms or asymptomatic or their severity, if you look, it's the patients that have aneurysms greater than 3 centimeters that have 45 degree of distortion or greater. Those are the ones that got into big trouble. Those are 19 out of 21 of those were thrombosed and having, significant limb ischemia. For whatever reason, I put this in here for board questions, but for whatever reason, hypercholesteremia actually decreases the ischemia risk in popliteal artery aneurysms. And that's not dependent upon, say, medical therapy. That's not, say, dependent upon statins, because that doesn't actually bear out. So the only possibility is perhaps because you have hyperlipidemia, you have global atherosclerosis, you have more chronic PAD, and you're able to tolerate more ischemia. And maybe that's the reason why, hyperlipidemia has a little bit less risk of ischemia in patients with popliteal artery aneurysms. So all this kind of leads to our second recommendation, which is, patients with asymptomatic popliteal artery aneurysms who are of good caliber, healthy patients that have an aneurysm over 20 millimeters should undergo repair to decrease your risk of thromboembolic complications and limb loss. Perhaps patients who are a little bit higher risk for surgery, especially if they do not have if they have no thrombus in the aneurysm. Those patients can be you can wait to operate on till they're 3 centimeters or more. But again, it has to be no thrombus. And remember, the risk for popliteal artery aneurysms is ischemia. It's not rupture, right? Although, those of us who practice long enough have certainly seen it. Thrombus is what's important here. Ischemia is what's important. And actually, when you talk about patients with thrombosed popliteal artery aneurysms, while if you look at all patients, the size is not as big as the thrombus present in the aneurysm itself. And that's, 29% of small popliteal artery aneurysms have thrombus, 15% of larger ones have thrombus. So it's hard to go off size completely. And even ones that come in completely thrombosed or are found completely thrombosed on scans. Again, the size is not a huge difference there. The presence of PAD, especially in the SFA, does make a big difference. So patients who have upstream significant peripheral arterial disease in the SFA, 50% of those patients generally have popliteal artery aneurysm, and their aneurysm has thrombus, as opposed to those who have no PAD whatsoever. There's a lot less. And when you look at this, we're talking about your runoff essentially, and how many vessels is taken out. Actually, when they looked at it in literature, the smaller aneurysms actually had worse runoff scores. And that was with a similar history of diabetes, a similar history of PAD, and a similar, risk factor, justification and looking at patients and similar medications. So again, even in patients that have a less than 20 millimeters, so less than 2 centimeter aneurysm, if you have thrombus or you have findings on imaging or on physical exam that there has been some kind of thromboembolic event, those patients should get treated and have repair, even if the aneurysm is less than 2 centimeters. Because again, thrombus is key here. So treatment. So we talked about how, when to treat it. So the question is, how do you treat it? Well, like everything else in vascular surgery, right? We have open surgery, we have endovascular surgery, or some kind of hybrid between them. Let's just go over some open popliteal artery aneurysm repair. And I put this in here for historic natures, but this is, comes out of JVS in 2003. Essentially, there's 3 ways when we fix these open. There's a type 1, which is, proximal distal ligation with a short segment bypass. That works really well for aneurysms that are, very localized in the popliteal fossa or just above or just below. Obviously, we have patients that have very long segment disease and sometimes have even SFA, severe peripheral arterial disease above. And so, you have sometimes type 2 exclusion where you have a much higher ligation away from the aneurysm, especially in the proximal section, and then a ligation distally. And then, historically there was this type 3, which is single ligation. And if you look at, how patients fared, depending on how you fixed it, the best way to fix this is type 1, right? So if you can ligate it just above and just below the aneurysm, do a bypass, that has the best chance of decreasing aneurysm diameter and having decreased risk of endoleak. And obviously that's because we don't have many patent branches, coming off the aneurysm then. Type 2 does fine as well, but not as slow of a growth as you can imagine, but you have a lot more branches in between that have a chance of feeding it. But you do have it, ligated distally, so you don't have really ischemic complications from the actual aneurysm. And then type 3 should never, ever be done because, you're leaving so many branches, you risk of embolus still if you don't ligate it below and you only ligate above. That's really more historical and should never really be done. So we just kind of talked about it here. Type 1 repair whenever possible. Type 2 is okay, and don't ever do type 3. As with all of our bypasses, right, conduit is key. There's a whole host of things we can use. Gold standard would be single segment great saphenous vein versus PTFE. The patency is much better. The limb salvage rate is much better, which you can see here. And even the secondary patency is significantly better with great saphenous vein than it is with PTFE. And that's independent of multiple risk factors for these patients. So if you look at PTFE, when you're talking about limb loss after undergoing popliteal artery aneurysm repair, the thing that makes the highest risk of you losing your leg, an odds ratio of 12, is using PTFE. So if you can use vein vein needs to be used. As far as the endovascular repair for popliteal aneurysms, overall, you have patency rates here from primary and secondary. There's been a big push about this, which we'll talk about in just a second. This is the study with the most generous patency I can find at a JVS in 2012. And even this study, which has the most generous patency for, Viabon grafting of the popliteal artery, it's still significantly lower than bypass. It's actually, almost the same as PTFE, maybe even a little less than PTFE, and way less than great saphenous vein or saphenous vein bypass. And so, it doesn't really matter how many stents are used or anything. The biggest predictor of stent graft occlusion and failure is runoff vessels. So if you have one vessel runoff and you're using a stent graft to treat your popliteal artery aneurysm, be aware that stent graft is going to shut down. It's going to go down, and you're going to have limb ischemia. If you have 3 vessels, and there's not a big difference between 2 or 3, but if you have 3 good vessels to the foot and patients are otherwise not a good candidate for bypass, those are maybe the only way you can treat it, only reason to treat it with a stent graft. A fair number of these grafts have stent graft occlusions. We all know that when these stent grafts go down, they go down hard, so to speak. Takes out quite a bit. Certainly, use of dual antiplatelet therapy decreases risk for stent thrombosis. I would be wary, obviously, with Plavix to make sure that your patient's a Plavix responder. And just like with AAAs, you do have a risk of type 2 endoleak here, and that happens in about 10.5% of patients. Obviously, one of the biggest problems with these stents behind the knee is stent graft fractures. And, that happens with all stents in that location because of, the flexion point of the knee. And the biggest real risk with that is the patient age. And that's really just a marker, I would imagine, for how active you are. The more active you are, the higher the chance you're having more flexion at that knee flexion extension, the higher your risk of stent graft failure, of stent fracture. And then when you have stent fracture, that always leads to, long-term problems with patency of the stent graft. And this just looks at long-term outcome of primary patency, primary cystic, and secondary patency over 144 months. And you can see this, study that even in this study with some of the best of the best in JVS in 2018, your patency long-term is not great. Okay, it's just not. And a fair number of them have thrombosis or reocclusion. Some of them needed, surgical thrombectomy, and then a bunch of them needed, a couple of them needed bypass. And again, stent fractures, are definitely seen. This is your freedom from stent fracture survival over the 12 years. You can see it's not very great. I mean, at 12 years, so if you have a young patient you think is going to live a long time, at 12 years, you're almost at 50% of them having stent fracture. So, treatment, what's better? Well, I can show you a million confidence intervals and things, but the primary patency of open bypass is much better than endo. At 1 year, at 3 years, when you're looking at occlusions for longest follow-up, if you're looking at occlusions at 30 days, if you're looking at amputation-free survival, right? Open surgery in this location is just better. It's just gold standard, okay? And this paper that was recent out of JVS in 2022 just shows you, okay? Here's your primary patency rate, open versus endo repair on a composite about a large number of patients over even just 2 years, okay? Open repair just fares better, okay? And this is your clinical presentation. So if you look here, the patients who have asymptomatic disease on clinical presentation do much better than the ones that have symptomatic disease. And why is that? Well, most of the symptomatic ones is either chronic limb ischemia, right, claudication, or acute limb ischemia. All those have usual thromboembolic problems taking off some of your runoff vessels. And when you have decreased runoff, we have decreased patency of bypasses and of endografts. And so if you can get to these patients when they're asymptomatic, they will fare much better than symptomatic patients. And so that's why, this leads this to the recommendation 4, which is for asymptomatic patients to have a good life expectancy, so greater than 5 years, okay, open popliteal artery aneurysm repair should be the gold standard in how you treat them. If possible, saphenous vein needs to be used, but even if not, PTFE is better than putting the stent graft in. You know, this led to a commentary by Farber at this paper about, you know, the real answer on treatment, you know, and he says that obviously a randomized controlled trial would be really helpful to eliminate any possible confounding or selection bias. You know, obviously those are very time intensive, they're very expensive. And when you have a disease that only affects up to 2.8% of the population, it's difficult to do because they're kind of more rare. There actually has been a recent attempt to do a randomized controlled trial for popliteal aneurysm repair, open versus endo, but it failed because of inadequate funding and difficult in recruitment of patients. And so this paper wasn't really part of the clinical guidelines, but I want to talk a little bit about acute limb ischemia and popliteal aneurysms because obviously it is such a big problem. And again, it's about a third of the symptoms that come in, and they can be real nightmares. And when you're looking at these patients, you know, we're looking at, you know, thrombolysis and group A or no thrombolysis and how they do, and how, you know, what is their chance of their bypass being patent, and how do these patients do over time? You know, patients who undergo thrombolysis preoperatively, if possible, do much better. Again, that's really because we're recruiting a lot more distal runoff, okay? And distal runoff is key. And this has been looked at numerous times. This is a meta-analysis paper looking all the way back to 1991, okay? And if you look at this, you know, the patency and your risk of having problems after your revascularization is much lower with those who underwent thrombolytic therapy. And that's been historic all the way back to 1991. And this is your preoperative thrombolysis improved results. So primary and secondary, you know, in those patients, patency after getting TPA first. You can just see, again, it's all about the vessel runoff. So the bottom is 1 vessel, right? 2 vessel, and then 3 vessel. So when you're looking at graft patency, 3 is better than 2, which is much better than 1. When you're looking at limb salvage overall, though, 2 and 3 are about the same. So you actually do okay, unless you have no runoff or only 1 vessel runoff. And that just looks at the trend here. So looking at the trend of lytic therapy versus no lytic therapy. If you look at your graft patency, much better with lytic therapy. If you look at your percent of limb salvage, much better with lytic therapy. Okay, they had very little people who underwent lysis and then revascularization, and that is usually open revascularization, who actually end up losing their limb, which is what it's all about, really. Okay. Unfortunately, you know, amputation-free survival is much better in men than women. This just looks at this kind of Kaplan-Meier survival estimates and curves. And just, you know, as of note, if you have a woman that comes in with acute limb ischemia and a popliteal aneurysm, they are going to do worse than men. That's been shown in numerous papers. This was actually a paper that's just article in press from JVS in 2022 this year. And it helps you because it helps you counsel these patients when you're seeing them in the ER, you know. Again, you know, the open repair is better than endo for these patients. Your freedom from major amputation was, 72% lower risk of having an amputation at 2 years when you do open repair, so open bypass, as opposed to doing stent grafting. So although open repair is much better, endovascular repair is on the rise. If you look at, the treatment of endovascular repair popliteal aneurysms, you can see from 2010 to 2020, the growth is pretty much exponential. It's increased significantly. So in 2010, there was only about 17% of popliteal aneurysms in the VQI treated with Viabon stent grafting or some kind of, stent graft. In 2021, it's over 85%. Okay, so even though all the literature says, hey, open repair is better, endo is on the rise like it is everywhere. All of this kind of leads to the last recommendation, though, which is, when you're looking at patients that have a thrombotic or an embolic complication in popliteal aneurysms, if possible, so if you have a Rutherford 1 or 2A, so again, you have just severe rest pain or you have some sensory loss but no motor loss, and if you have obstructed tibials, those patients should undergo thrombolysis and pharmacomechanical intervention prior to undergoing definitive revascularization. The one time this changes is if you have a patient, okay, that comes in with motor and sensory loss, and you need to do emergent revascularization, and you're not going to do this with open surgical thromboembolectomy, okay, which sometimes can be very difficult because a lot of this thrombus goes down into the toes and the feet and everything, and sometimes dripping them for a long period of time does a lot better. That might be the only case where you actually put a stent graft behind the knee, repair the popliteal artery aneurysm, and leave a lytic catheter to drip the entire time. Now, that being said, we all know those patients are going to have a worse outcome from a limb salvage and a stent graft thrombosis long term, and that would be, in my mind, more of a bridge. So you get them out of the emergent thing, and then understand and let them know that we're going to be taking you back, and you're going to need a bypass, especially if they're young. Now, if they're very ill and very frail, maybe not. But if they're very young or they're relatively healthy, so when we look at these patients and their EF is normal and they don't have severe coronary disease and they're not on oxygen with COPD and they don't have some severe stage 3, stage 4 cancer, that might be the bridge to eventually bring them back for a bypass. And obviously, just like with anything else we do, if you come in with Rutherford grade 3 acute limb ischemia and a non-salvageable limb, they should just have amputation. Follow up, after treatment, whether it's bypass or endo, needs to be done just like we do with any other portion of our revascularization to help you with your primary assisted patency. This is another guideline that comes out of SVS, published in 2018, which you can get. I won't belabor this because it's a little bit off the topic, but this is just looking at duplex criteria for your infrainguinal vein grafts. Certainly, we have the same ones for open inguinal repair and endovascular fem-pop repair. We have similar kind of guidelines to follow here, looking at different thresholds of when you should be intervening. The take home really is, once you intervene on these patients, just like we do anything else with vascular surgery, and like I tell my patients, when you're a vascular patient, like you're a vascular patient for life, period, end of discussion. This is not, like a gallbladder or an appendix. We're not going to see you like one time, maybe like 3 months later, you're doing fine. That's all we're doing. This is a lifelong process. They need to be surveilled, pretty heavily. So initially, right afterwards, at 3, at 6, at 12 months, and then if everything's perfect, at least yearly, okay? And when you find something on these duplexes, whether it's a lower velocity suggesting higher flow obstruction above, or elevated velocity, or some kind of change of 150, 300% between the step-ups, between the segments, or your ABI drops more than 0.15, these patients you need to be aggressive with and evaluating them, whether that's with CT angiography or diagnostic angiography, to figure out what is going on, why are they having a problem, because you can obviously make a big difference here in keeping your primary assisted patency, which will then obviously lead to better limb salvage long term.
Exactly.
As far as the non-operative popliteal aneurysms, when you're looking at, this is a paper from 1996, but just looking at who gets who has a problem, the mean time to complications is around 1.5 years, and anybody within 5 years is actually over 50%. So you definitely have to follow them. They should be monitored at least annually, and you really need to look at them for symptoms, pulse examination, extent of thrombus, and again the outflow arteries, because all of those things would be determining when you fix them, right? So, hey, did it get bigger? Is it over 2 centimeters now and the patient's relatively healthy? Hey, do we think there's, some kind of clinically silent, thromboembolic thing going on where you're taking out tibials? How much thrombus is in there? Did the thrombus grow in there? Is there now thrombus in this aneurysm? Because all those things would be time for operation. So in conclusion, you have to have a high clinical suspicion, especially in vascular patients, especially high-risk patients, again, men, especially with larger abdominal aortic aneurysms, because asymptomatic patients do much better, and you have to treat them early. Again, while size is important, and historically and on boards, it's always 2 centimeters or 3 centimeters now for patients, who are poor protoplasm. Thrombus is key. If you have thrombus, it needs to be fixed. When possible, thrombolysis is needed. And then single segment great saphenous vein is good.
There's someone
and then
speaking
again, post-treatment, you need to surveil them often, and don't be afraid to act on your findings. And those are my references. Questions?
Any questions? Yeah. Dr. Carmen, I have a couple of questions from the audience here.
Okay, yeah.
Who's going first? Come close to the machine. Thank you.
Yes, thank you.
We have Dr. Uche Gregory.
Thank you, Dr. Piccolo for the presentation. It makes sense. I'm just thinking, and the reason why the high risk for fracture of the grafts, or the stents rather, fail is because of the frequent movement at the knee joint. So I was just thinking, and if you believe that in the future there might be a better form of graft that will resist such frequent deformity that puts the stent at the risk of getting fractured. I would just want.
I mean, you never know. Obviously, as we all know, the vascular space is a growing space, and we do a fair amount of research, and industry does a lot to try to help with that and drive it for multiple reasons. Obviously, will we ever have a stent graft in the future that has such good conformability and has such good compliance? There's less risk of fractures, perhaps. I mean, we do have some of those from a non-covered stent. So if you look at some of I think it's BG has one, and Abbott has a Superior stent. Some of those have less stent fracture rates, inflection points, because of the slinky kind of way that they're made. Now, those, as any of you know who have deployed those stents, those are very difficult to deploy accurately. And while they have less risk of stent fracture in those locations, and I have personally used them in certain locations in PAD in patients who maybe aren't good bypass candidates, who don't have good conduits or what have you. But while they work really well, they're difficult to deploy. And if you deploy them outside of their length, so like if it's a 100 length stent and you deploy to 120, your patency drops significantly. And so it has to be accurately deployed. So, I think not only do they need to figure out the technology of how can you have a scaffolding that can be used to cover the endoprosthesis that won't fracture, but then also how are you going to have one that allows you to deploy it accurately enough where you don't have that, and we all know that from all of these stents that deploy like this, whether it's the Bard Life stent or the Abbott Superior or the BG, I'm blanking on the name, stent that is supposed to be for flexion areas. When they're extended on your deployment, which, some of them are, like I said, some are easier to deploy than others, your patency drops significantly. So, yeah, I mean, hopefully one day in the future we have it, but we definitely don't have it now.
Thank you.
One question more for you.
Thanks for the talk, Dr. Piccolo. Just a question. Patient that has infrarenal aortic aneurysm and large asymptomatic popliteal aneurysms associated. What would you treat first and why? How would you approach?
So if it's a completely asymptomatic popliteal artery aneurysm and it's a large AAA, I treat the AAA first, and then after they heal from that, I go back and treat the popliteal. Particularly if the aneurysm and the popliteal is size enough or has any thrombus in it, I'd fix that.
Very good. Any more questions from anyone?
I didn't hear the last thing.
Could you repeat the last thing he said?
I said particularly, obviously depending upon how much thrombus is in your popliteal artery aneurysm and your size of it. But if like we talked about, there is thrombus in the aneurysm, the popliteal, or it's large enough to fix, and then you have a large, concomitant AAA, I would treat the AAA first and then the popliteal afterwards in a separate setting. Because additionally, I'm going to be doing it differently. I'm not going to be coming from the top in an antegrade fashion or up and over and stenting it. I mean, I'm personally thinking about we're going to fix this with bypass. I guess if there's no chance of you fixing it with bypass and you were going to be in the groin anyway, and you were not going to do the aneurysm percutaneously, and you were going to cut down on the common femoral, I guess you could go retrograde, antegrade right there from your femoral exposure and put a Viabon or whatever it is across the popliteal artery aneurysm to save them a trip and save yourself a cut down, especially because it's going to be harder to come up and over with the endograft in place. But, if I had my preferences, I would do the, whatever I'm going to do for the AAA first, and then in a separate section, come back and do the aneurysm and the popliteal.
Hey, Carmen, would you have any experience so far with explantation of the Biobond stent that you've used to treat a popliteal aneurysm, then conversion to?
Yeah. I haven't had to explant any, like from like infection or any reason. I have certainly bypassed around them and thrombectomized, the distal outflow when the Viabon has gone down, either from here or from other institutions where they come in with acute limb ischemia that has a Viabon in the popliteal. Some of that's for PAD and some of it's for aneurysmal disease. I haven't had to ever explant one, but I've certainly had to, bypass around it. Yeah.
Okay, very well. Thank you so much, Carmen. Appreciate your ability to help us out of this endovascular conference for Africa. We hope to see you next year. Thank you so much.
Yep, let me know. Thanks. Have a good day. Have a good conference.
Okay, bye-bye.
Bye.
So let's bring in our next speaker, who had no problem with connection. Nabila Ahmed will be giving us a quick talk on hybrid intervention techniques. Or is Dr. Lynch ready instead? Oh, Nabila, go ahead first, and Dr. Lynch after you. Okay, go ahead. Go ahead.
It is. Okay. Yeah. Okay, good morning. I hope you guys can hear me okay.
Yes.
My name is Ahmed. Awesome. My name is Nabila Ahmed. I'm a third-year medical student at Lincoln Memorial DeBuss College of Osteopathic Medicine. I want to start off by thanking Dr. Oye and the organization for this opportunity. It is a great honor and a pleasure to participate at this conference, and I'm delighted to be here today virtually. So without further ado, I'm gonna go ahead and get started. My case report is, or my presentation is on a case report on hybrid endovascular procedures. So critical limb ischemia is a severe form of peripheral arterial disease and is characterized by the clinical findings, lower extremity ischemic pain at rest, and or ischemic tissue loss marked by ulcerations and gangrene. This affects about 500 to 1,000 people per million per year in the West. At 1 year, only 45% will remain alive with both limbs. About 30% will end up needing an amputation, and 25% of these patients are expected to pass away. And then furthermore, unfortunately, within 5 years, more than 60% of these patients will be deceased. Therefore, it's vital to manage and treat these patients with peripheral arterial disease before they progress to critical limb. So as far as management goes, revascularization is key for limb preservation, and it has traditionally been accomplished with open surgical bypass. These types of surgeries have a well-established patency benefit and are typically the preferred method for complex cases. But unfortunately, they do run a high morbidity risk of 8.3% and a mortality risk of 3.3%. However, in the past 20 years, there has been a fourfold increase in the utilization of endovascular procedures because these advancements made with catheter-based technologies that allow it to be done in a minimally invasive fashion. Some of these advancements include specialized catheters, crossing wires, and re-entry devices. And there has been increasing experience in the utilization of these techniques among specialists. So because both open surgeries and endovascular techniques have their own benefits, the idea of combining the two has led to the creation of hybrid intervention. Hybrid intervention is defined as a combination of both open surgical and endovascular procedures concurrently during a single operative setting. There has been a shift towards the utilization of these techniques because its benefits include decreasing delays to complete revascularization, the ability to immediately repair inadequate endovascular results, immediate angiographic confirmation of revascularization, and shortened hospital stays that are very cost-effective to patients. So initially, these were used for the management of peripheral arterial disease, but more recently, they account for about 5 to 21% of vascular reconstruction. The indications for use include peripheral arterial revascularization. Okay, so now I'm going to go into a case that I had the pleasure of seeing with Dr. Oye, in which the utilization of hybrid interventions was considered. So we saw a 67-year-old male patient who presented with a right lower extremity pain that started about 3 months ago. He reported pain from the mid-calf down, and he stated that taking Motrin made it better. The patient reported no sensation in the right lower limb, and his past medical history was extensive, including atrial fib, coronary artery disease, prostate cancer, congestive heart failure, diabetes, heart murmur, AAA, myocardial infarction, and hypertension. His past surgical history included a AAA repair, and he had a 52-year smoking history, 1 pack per day. So preoperatively, he was diagnosed with peripheral vascular disease, right iliac occlusion with right femoral popliteal stenosis, and a right foot wound. The patient's non-healing wound on his foot was considered limb-threatening. And because he had a previous aortobifemoral stenting for aneurysm repair, it was decided to consider a fem-fem bypass initially for limb salvage and a femoral popliteal bypass if necessary. So the procedure started off with making a bilateral groin incision that was made to expose the common femoral, the SFA, and the profunda. A vessel loop was then applied to these vessels. 600 units of heparin was given to the patient, and then a microvenous needle was used to cannulate the left common femoral artery, and a 4 French sheath was introduced with the findings of patent aorta and with the left limb of the aorta bifem bypass illustrating the stenosis. A 6 French sheath was advanced and crossed with a 0.035-inch guild wire. Angioplasty was performed with a 9x40mm Dorado balloon with improvement. An 8x50mm ringed Gore-Tex graft was tunneled from left to right and was cut to match the enterotomy on the left profunda with good suture repair. And it was also cut to match the enterotomy on the right with good suture repair. There was still marked calcification, extensive plaque buildup in the proximal femoral and common femoral artery, which were then cannulated with microvenous needle, and the sheath was put in place. There was evidence of stenosis of the artery at that level, as well as above the knee segment. Balloon angioplasty was then performed with residual stenosis requiring an Eluva 7x40mm stent. It was taken to the target area and deployed at the above the knee area with excellent improvement. Then this was followed by post-balloon angioplasty using conquest balloon with good opposition in the wall and the area of the SFA close to the plaque. And arterectomy was also ballooned for about 90 seconds. And lastly, an end arterectomy patch was performed using good suture repair. The patient did tolerate the procedure well, and no further complications were reported at the time. Here's an image of the plaque that was removed from the patient. So this case highlighted that hybrid approaches combining fem-fem bypass, end arterectomy, and angioplasty with stenting are viable options for the management of iliac occlusion with fem-pop stenosis. They are safe, efficient, and durable. And because these interventions are not solely open-based surgeries, they reduce the physiological stress associated with aortic cross-clamping and laparotomy. So in conclusion, hybrid interventions have gained momentum because they are less invasive and can improve patient outcomes. Their simplified approach makes them cost-effective with 50% cost savings. Now they have become more mainstay in the treatment of complex cases with multiple comorbidities and advanced age. And lastly, hybrid procedures are expected to evolve in the future of vascular surgery. Thank you for your time. I'm going to go ahead and pass it back to you, Dr. Oye.
Thank you very much. Thank you. Good job.
Thank you.
The hybrid procedure is a nice technique when you endovascular alone does not work and you're trying to avoid the major open surgery. You can do mini open and percutaneous at the same time. So that endovascular at the same time, and that kind of helps. So thank you so much, Nabila. Okay, let's go. Thank you. So our next speaker will be coming to us from Pennsylvania, and that's Dr. Gregory Lynch. He's an endovascular vascular surgeon who does a lot of venous work. He's going to talk to us about the interesting use of percutaneous AV fistula access for dialysis. So Dr. Lynch. Beckley, can you hear me? Beckley?
We can hear you.
Okay. How about we go up with Dr. Hayek while Dr. Lynch takes care of his technical component. So let's Dr. Hayek get ready for our talk.
Okay, we'll tell her to sign in right now. She was going to sign in a few minutes.
I'm here. I'm ready.
Oh, you're here.
Okay.
Perfect.
Yeah, can everybody hear me?
Very well, Dr. Hayek. Thank you for coming. Dr. Sarah Hayek is a trauma general surgeon as well as bariatric surgeon. Today she'll be presenting on vascular trauma from the perspective of a trauma surgeon. We're grateful that she's doing that today. She works at a Renal General Hospital in Beckley, West Virginia, and we're pleased to have her come on board today. Thank you. Acute abdomen, she'll take that back. Acute abdomen is Dr. Hayek, not trauma. Thank you very much, Dr. Hayek.
Of course. Thank you. Can everybody hear me?
Yes.
All right.
Yes.
Excellent. Well, good morning, everybody. Thank you so much for having me. This is such a pleasure. It's nice to be able to do conferences again, and I'm sorry, obviously, I can't be there in person, but it's still nice to meet with colleagues. So as Dr. Oye said, I'm a general surgeon, and I was just asked to do a little bit on the acute abdomen. So we're going to kind of come at it from a big overview, because obviously this is a huge topic. I have, let's see, will it progress? There we go. I have no disclosures. So just as an outline of what we're going to talk about this morning, how does the acute abdomen present? What are some of the causes of acute abdomen in our patients? How do we do evaluation and workup? And then treatment. And since this is a vascular conference, we'll spend a couple of minutes on some specific vascular pathology. All right, so the presentation, how are these patients going to come in? They're going to come in complaining of pain, of course. Nausea and vomiting are also very common, as are cramping and alterations in bowel habits. Some of our patients are only a little bit ill, and others can be very, very sick and hemodynamically unstable at their time of presentation. So what causes a patient to have this type of pain? I think of these in kind of different categories or buckets. I think of infectious etiologies, inflammatory, vascular, obstructive, and then traumatic. So in the infection, I'm thinking of things like acute appendicitis, cholecystitis, pancreatitis, and diverticulitis. Inflammation, I'm thinking gastroduodenal ulcers. Inflammatory bowel diseases, often patients can end up with flares of inflammatory bowel diseases, poorly controlled inflammatory bowel, and can come in quite acute then. And then malignancy is also something we need to keep in the back of our minds. Vascular, we're going to think about mesenteric ischemia. We're going to think about low flow states. If the patient is having some sort of cardiac event, sometimes that can also cause acute abdomen at the same time. So we need to be thinking about that as well. Embolic events and aneurysms, as well as aneurysmal ruptures. Obstruction, we're thinking malignancy, hernia, volvulus, and then of course trauma, bleeding, organ rupture, hematomas, and then injury to nerves and musculoskeletal system can also present as an acute abdomen, and kind of mix the picture and get a little bit confusing if you have something like a bad injury to a rectus muscle or something. Then we think about children. Children present a little bit differently. Although they still have kind of the same categories, their presentation will be a little bit different, as well as the causes of it. Acute appendicitis, very frequent in our childhood population. Bowel obstructions do occur, but they're occurring for different reasons than they are in our adult population. Here we're thinking of things like malrotation and intussusception. These are more pediatric-based disease processes. Necrotizing enterocolitis in our really tiny, tiny babies, and pyloric hypertrophy as well. So what should you do when the patient comes in and they've got these symptoms? Because obviously that differential is just so large. So how do we narrow this down? First, we start off with a really good history, figuring out symptoms of pain, nausea, vomiting. In the pain, it's really important for us to figure out the quality, duration, and the location. So there are a couple of different ways that we think about the location in the abdomen. We think in quadrants: right upper, right lower, left lower. And then we also think of some other areas, and that's what's shown on the left side, is the epigastric, the periumbilical, and the pelvic. So those are kind of more specific areas of the abdomen as well. And when we're doing this workup, we want to be thinking about what's under there. What am I feeling? So we kind of think in anatomic terms. What is contained in that right upper quadrant if that's where the patient is having pain? Could this be something coming from their liver or gallbladder? Certainly, but there are other things that exist in the right upper quadrant as well. So think about the duodenum, could be a duodenal ulcer, hepatic flexure of the colon. So we have lots of anatomy that exists in each quadrant. And then we have to think when we're in the lower quadrants also about pelvic anatomy. And are we thinking reproductive organs, especially in our females? Are we ruling out things like ectopic pregnancies, ovarian torsion, those sorts of things as well as GU issues with ureters, kidney, bladder. So some imaging studies. Ultrasound and X-ray, along with your physical examination, are often enough. Those of us that are blessed with facilities that have easy access to CT scanners have gotten used to it, and it's something that we kind of order reflexively. It's great and it can absolutely help you with your workup, but it's not always necessary. Ultrasound and X-ray, along with your physical examination, should be able to diagnose the vast majority of abdominal pathology. CT scan can help. CT scan with IV contrast or with oral contrast, when appropriate, can be very useful, but sometimes takes a little bit longer. MRI is almost never necessary for an acute abdomen, and you usually don't have that kind of time. Laboratory evaluations you should be thinking about: CBC and CMP, see if that leads you in any direction. Lactic acid as well, if they're presenting as a truly acute abdomen and very ill. Other studies to consider: in your reproductive females, pregnancy test, and in anyone over the age of 40, it's not a bad idea to get an EKG, as sometimes cardiac pathology can actually present as an acute abdomen. So now treatment, how do we deal with these patients? For hemodynamically unstable patients, we're going to be thinking about stabilizing them first. So they need blood transfusion and they need fluid resuscitation. If they are a traumatic injury, you may think about going immediately to the OR. Otherwise, you need to do a little bit of stabilization first. So get that fluid in, get those blood products running, if available to you. If you're thinking sepsis, you also want to add IV antibiotics, specifically covering gram-negative organisms, as this is often the cause of sepsis from the abdomen, would be a gram-negative organism. And then make sure that we're getting immediate surgical evaluation. It's often going to start off with a general or trauma surgeon, maybe a vascular surgeon. Maybe you are lucky enough to have somebody who does all of those things. For a hemodynamically stable patient, it's going to be a little bit different. You're going to be looking for the cause and to treat the disease with symptom control. And you usually have a little bit more time with these patients to figure out exactly what's going on. You can get that CAT scan. All right, so let's talk about vascular acute abdomens. There are a variety of vascular emergencies that can occur in the abdomen. Thankfully, they're somewhat infrequent in comparison to the other pathology, but they can be catastrophic and are often deadly. Delay in diagnosis is one of the most common causes of patient death. Patient will come in having abdominal pain, worked up by an emergency room physician or a nurse, and we kind of miss the large pathology that may be a ruptured abdominal aortic aneurysm. Any delay in a vascular abdominal emergency really can very quickly, unfortunately, lead to patient death. So these are important to have a high level of suspicion for. I think of these in two categories: occlusion and ruptures. So occlusion, we're thinking arterial occlusion or even full aortic occlusion. And then rupture, we're thinking aneurysms that have ruptured or traumatic injuries typically. So of the occlusions, obviously any artery can become occluded, whether it's an acute occlusion or a chronic occlusion. Anything can become occluded, but some of the things that cause the most significant pathology for our patients would be the larger blood vessels, the root coming off of the aorta. So celiac, superior mesenteric, inferior mesenteric, and splenic. These pathology usually develop with pain or crampy type pain, sometimes with a GI bleed. You can often identify where it is based on physical examination, if it happens to be in one particular quadrant, but sometimes, you know, if it's your superior mesenteric artery, it may be kind of generalized abdominal pain, so it may not be very apparent. So again, high level of suspicion. These can be your patients who, you know, have things like smoking history, have a history of some sort of cancer going on, are hypercoagulable for some reason. So you need to be thinking about this early on in their disease process. And then alleviating the obstruction, either through angioplasty, bypass, removing any dead or necrotic tissue that may be associated with that occlusion. An acute occlusion is definitely an emergency. The chronic occlusions can occur as well, and you may have a little bit more time on those patients. Then rupture. Obviously, I'm sure most people here are familiar with this, but rupture size matters for your aneurysms. So anybody who comes in who you identify aneurysms on prior to an acute event or an emergency, we want to think about, do we need to intervene on this patient yet? How do we avoid them getting to the point of rupture? So prevention is really the key. For your abdominal aortics, at least in North America, we kind of see size runs with risk of rupture very closely. So we kind of think about those aortic aneurysms. If they're small, then your risk of rupture is low. As those get larger, the risk of rupture gets higher. This is a great conversation to have with patients if you can, to say, you know, this is the size that you're at. These are the risks per year of rupture. In patients who are medically fit to undergo a repair, we really should be thinking about repairing them when we can. Are, of course, other aneurysms that occur and that can rupture. So splenic aneurysms, these should be repaired when greater than 3 centimeters and should also be repaired in all reproductive females. Their rupture is fairly frequent in comparison to other ruptures and can cause life to be lost either from the mother and or the fetus as well. There are a whole other group of other ones that we like to repair regardless of size: SMA, gastric plug, pancreaticoduodenal, GDA, colic. Your celiac, jejunal, and ileals are going to be over 2 centimeters, and then renal arteries are greater than 3 centimeters with symptoms or in your reproductive females, and also in people who have refractory hypertension. This may be contributing to that. That's all I had for my presentation, but I would love to take any questions, see if there's anything that I can be of assistance to for anybody.
Thank you. Dr. Hayek, one of the things that we see in the emergency room, as you ably stated initially, the most important thing when you encounter patients is history and physical.
Yes.
And the physical examination is critical for the vascular patient because if the examiner does not touch the abdomen, they would not know the person has an abdominal aortic aneurysm. And I've seen it happen, and where the ER physician indicated that the abdomen was tender in the right lower quadrant, the right lower quadrant, and said, well, diagnosis appendicitis, cholecystitis, diverticulitis, where the patient had an obvious large abdominal aortic aneurysm that went on to rupture several hours later. Again, for the audience, if you have an abdominal aortic aneurysm or suspect of abdominal aortic aneurysm, AAA, immediately, if you have access to ultrasound, you can have an idea if it's an aneurysm. If you don't have an ultrasound now, as we have the point of care ultrasound that we just talked about yesterday, you can really see if they have an aneurysm issue. But if that's not the case, if you have access to a CT angiogram study, do not order a CT of the abdomen with IV and oral contrast if you know you're going for an abdominal aortic aneurysm, because if you do, they will give large amount of contrast, and they'll have to wait for the oral contrast to go down and then do the test in about 2 hours later. And in that time space, if you do have an abdominal aortic aneurysm that's impending rupture, you may rupture before. So at minimum, you can even do CT of the abdomen without contrast if the patient has renal issues. But if they don't, just do CT with IV contrast only, so you can at least delineate the aneurysm. And if you have ability to do a runoff, like Dr. Piccolo mentioned in his previous talk, because the association of additional aneurysm in the iliac, femoral, popliteal, you might be able to see that. So when we order CT with contrast, IV contrast, we typically do runoff for vascular cases. Yeah, so that's very, very important. So it can be fatal if you miss an abdominal aneurysm with that leads to potential rupture, even in a hospital setting. Okay.
Absolutely.
Thank you very much. Any other questions for doctor before I let him go?
Can I just share a
Here's a question here.
Thank you.
Come.
Okay. Thank you, Dr. Sarah, for the presentation. I'm just wondering if a patient that was presented to us could have had an occlusion of one of those major vessels. This is a patient that presented to us late, previous hospital. When we took him in, what we found was an extensive granulous small ball. We have just about 10 cm of the ileum left, it's like the distal part left. The entire jejunum almost gone. So we had to do a resection and anastomosis. We couldn't find anything else. That is most likely a vascular occlusion. Most likely, we just left it like that. From what you presented now, I'm just wondering if that patient had presented to me earlier on, I think it was like 2 days in that hospital, the referring hospital. If the person had presented to me, what would have given that diagnosis of, presuming that that was the case? What would have been up and make me have this suspicion to go the whole gamut of investigating, like you said, with abdominal ultrasound, physical examination history, that should be okay. One shouldn't just rush at doing the CT angiogram.
Yeah, that, Sarah.
I think I got some of it,
He's
but not all.
saying he had a patient that presented to him later in the course, and upon exploration, there was a near total bowel gangrene, and the distal jejunum was ileum was intact, so they did anastomosis, and transsectional anastomosis. He was asking what would be the diagnostic clue that you would give for them to have suspected that the person had a dead bowel before they even opened?
Pretty much physical exam is what I go on these patients, as well as lactic acid. Many of these patients are acutely ill and they get sick very quickly. So when they're getting sick much faster than I kind of anticipated, then I'm thinking, is there something vascular going on? They sometimes also will have other things. You can see some duskiness sometimes in some extremities. If you're seeing some blood flow issues to other areas of the body, definitely something I'm thinking about. Lactic acid rising really quickly. And then physical exam usually presents with, was it pretty diffuse abdominal pain? That's when I get pretty nervous, when it's getting diffuse and peritoneal. That makes me think that we may have a catastrophic event underlying.
Usually if the pain is out of control, your physical examination also tells you something bad going on. Yes, that's correct. And also the bicarb level, if you're seeing they're acidotic, that's a clue. If your patient's quite acidotic and they have bowel pain, you may want to think that they have something going on there. That's related to blood supply. Okay. And with that, one more question from Dr. Shelley, I believe.
Thank you.
Dr. Shelley, you have a question?
Oh, okay. Thank you very much, Sarah. Part of my question has been answered, but I would just want to find out. We know that the causes of acute abdomen in Western countries is a little bit different from what we have in our own climate. What is the ratio, or how frequently do you encounter vascular causes of acute abdomen in your environment against other causes like infection, appendicitis, malrotation, intestinal obstruction. So my question is, how do you really cone down to say this is vascular as compared to other cases? Because you won't just do all the gamut of tests for the patient. How do you select, your investigations? Because here we are very prudent with investigations and they are not even available. So
Right.
how do you approach these patients? That's my question.
It's a great question. So of course, in the United States, we are blessed with having access to a lot of things, and we get, I think, spoiled. So we tend to image everything and start there. But I think the best way to do it is, from my approach, we see mostly non-vascular. We do see some vascular, but the vast majority of my pathology is non-vascular. So I'm looking for the most common things. So that's going through that. Is it infectious? Is the white blood cell count elevated? If it's infectious and I think that they, look like they're septic, then I need to be looking for acute appendicitis, cholecystitis, the inflammatory processes. If I know they have a history of bowel disease, I'm obviously going to be thinking more towards the bowel diseases. Going through kind of my breakdown of the most commons, correlating that to my physical examination. Does this meet up with, oh yes, they have right lower quadrant pain. That's most likely. When those start to deviate, when my most commons aren't being ticked off, or my physical exam isn't meeting up with the common pathology that we as general surgeons see, that's when I start to think there's something else underlying here and it's not in a general surgery bucket. Maybe it's vascular. So really, truly, physical exam and history should be able to tell us the vast majority of general surgery pathology. If we start to get out of that, now we need to be thinking things like a vascular pathology or something infectious that, doesn't kind of stick to one organ system. Those are when we really need to start branching out. Ultrasound is probably going to be the most universally available. So that's a great place to start.
Thank you.
The doctor, Dr. Precious, can pick it and
All
administer
right. For the interest of time, we're going to move on. Thank you, Sarah. I appreciate it so much. Thank you.
Have a great day, everybody.
Our next speaker will be Dr. Gregory Lynch. He's coming to us from Pennsylvania, USA. He'll be talking to us about the creation of percutaneous AVF fistulas.
You'd need to unmute yourself, Dr. Lynch. No, we can't.
Can hear. Can't hear.
No, sorry. Right on the bottom is where the camera symbol is the mic button. Your screen is muted right now. No. We still can't hear you. Would it help to
We can hear you now.
sign on?
No, we can hear him. Can you say something? No, can't hear you. Oh, you're still muted. Now.
Would you be able to click that mic button again? It's showing us you're muted.
That's it. Nope.
I don't think he has the microphone on this device, so. So can you share an earpiece or something? You can use one microphone. You can get an external microphone for the earpiece. I will work fine.
Let's see. Can we move on to the next speaker and come back to him then, if that's the case? Is Dr. O ready?
Yes, she is. She's ready right here.
Let's get Dr. Ourania, and you can work with Dr. Lynch to get his machine to work. Okay. Dr. O, ladies and gentlemen, our next speaker would be Dr. Buki Olatubosin. She's a general surgeon who would be talking to us today about vascular trauma. And Dr. O works at Renal General Hospital in Beckley, West Virginia. Dr. Olatubosin, welcome.
I can start?
Yes, you can.
Okay. Good morning, or I don't know, afternoon, I guess, everybody. As you said, my name is Dr. Olatubosin. I'm one of the general surgeons in Beckley, West Virginia. Before starting this presentation, I have nothing to declare. Like Dr. Oye said, I will be talking about vascular trauma. At least over in this area, vascular trauma, it gets a little bit of there's a lot of argument as to who should handle vascular trauma. Should it be the trauma surgeon or should it be the vascular surgeon? And there's a lot of arguments about who should do that. But I'm not going to go into that. I'm just going to focus on what we as general surgeons and trauma surgeons focus on, the vascular injuries. So with every trauma you get, regardless of whatever is driving it, you must always focus on the algorithm, which is ABCs, airway, breathing, and circulation. You must always focus on that first before you actually go to the next step, which is identifying the cause of the pathology or injury. So when you're looking at vascular injuries, you're looking at, when a patient comes into the hospital with signs of vascular injuries, you're looking at soft and hard signs. Hard signs are things that tell you you have to take the patient straight to the operating room for an operative intervention, which means that there will be no additional testing, no additional imaging done. As the patient walks in, for example, with pulsatile hemorrhage, you know they have to be controlled vascularly. If they have thrills or bruits or there's any evidence of acute ischemia, usually to the extremities, the patient automatically goes to the operating room after securing the ABCs. Soft signs usually tell you that you have a little bit more time to try and figure out what's going on, if the patient actually has an acute vascular injury or not. Injury patterns. So penetrating injuries, you're looking at gunshot wounds and stab wounds. Blunt injuries tend to be more common. You find that with motor vehicle accidents or falling sometimes. The vascular blunt injuries, you find that a lot with people who fall from heights. You also have free versus contained bleeds. You have atriovenous fistulas. You have iatrogenic injuries. In general, the goal is you need to decide whether you're going to pursue definitive repair, which is the patient has like a venous injury or an arterial injury, you're going to fix it at the moment, or you're going to do what we call damage control. So damage control is just enough to maintain the patient, because sometimes some patients have so much significant injury, general overall injuries and multiple system injuries, that you cannot actually pursue definitive repair at that moment because the patient is so sick. So what you tend to do is you do damage control. So you stop the bleeding, you clamp the vessel, you ligate the vessel, and you come back and fight another day after you get the patient stabilized. Then we also talk about open versus endovascular. I think that itself is very self-explanatory. There's also a lot of debate in the trauma world about endovascular surgery coming into trauma. There's still some trauma surgeons out there who strongly believe in sticking to open repair for trauma. And obviously there's some who have been incorporating endovascular repair into traumatic vascular injuries. The positive of vascular injuries is that overwhelming majority of patients who come in with vascular injuries tend to be young. And so you don't tend to deal with the same pathology that a regular vascular surgeon would deal with when it comes to vascular pathology like peripheral vascular disease and things like that. So what are the options you have in front of you when you have a patient that comes in with any concern for vascular injury? There's observation, right? So if it's something that is not life-threatening or you don't think it's going to change the course of the patient's life. You can absorb the patient. You can ligate the vessel. There are many different vessels that you can and cannot ligate with impunity. For example, you can ligate the external carotid, the celiac axis because of the collateralization, the internal iliac. You have end-to-end anastomosis. You have interposition grafts. You can use a vein for, usually the saphenous vein is the most commonly used graft for that. PTFE, Dacron. And sometimes you have to do extra anatomical bypass. And thanks to the advancement to interventional radiology has actually been able to be incorporated into trauma interventions, both for general, but mostly for vascular traumas. For endovascular repair, you usually do that for hemodynamically stable patients. So you don't see someone coming in with a carotid artery injury that is rapidly bleeding, and then you call for the IR team to come in because the patient will be dead before you actually can get anything done. But for injuries to areas that are a little difficult to access, this is where people make the argument to actually use endovascular surgery. So for the vertebral artery, for example, for the renal artery, repairing the subclavian, or blunt descending thoracic aortic injuries are great for endovascular repair. So operative principles, the most important operative principles when it comes to repairing vascular injuries are you have to get proximal distal control. So one of the first things you have to think about is, where is the injury? How can I get the best exposure to allow me to get proximal and distal control so I can actually focus and deal with the injury itself? This is typically in any vascular trauma, wherever you are, in the chest, in the head and neck, in the abdomen, in the extremities. Proximal and distal control must come first. So I'm going to go through different zones. We have zones of the neck. This is one of the most commonly talked about vascular traumas that we have to deal with, right? We have zone 1, zone 2, and zone 3. And based on the diagram, you can kind of see where they go. So zone 1 comes from the sternum to the cricoid. Zone 2 is the cricoid to the angle of the mandible, and zone 3 is from the angle of the mandible upwards. Zone 2 is the one that we tend to deal with the most and tends to be one of the most lethal traumas you would get. Zone 3 is very difficult to get to, and those are the injuries that endovascular surgery and IR will be phenomenal for. Obviously, most people who come in with zone 2 injury also have other injuries because, like we say, the area of the zone 2 area has a lot of high real estate anatomy. So you're thinking of trachea, you're thinking of esophagus, you're thinking of some pretty important nerves, and obviously the carotid and the internal jugular vein. So over in there that airway must first be obtained before you pursue anything else. Again, ABCs, right? Asymptomatic patients with penetrating injury to zone 1 through zone 3 require full vessel angiogram. So if a patient comes in and they are clinically stable, or there's concern for any injury to any of the zones, you can get a CTA, you can get an angio to figure out what the injury is. If a patient that has zone 2 injury, also stable, you can also get a CT angio. But if a patient with zone 2 injury with any of the hard signs I talked about earlier, they go straight to the operating room. So there's no imaging for any hard signs in zone 2 injury. Blunt cerebrovascular injury. So these are a little more difficult to deal with, and there's no consensus exactly on how to handle them. As you can see here, incidents of clinically significant injury to the carotid and vertebral artery are 1 to 3 per 1,000 patients that are admitted to trauma service in the United States. With increased screening protocol, the incidence is increased because we're picking up a lot more. So a lot of these tend to be actually asymptomatic, usually intimal tears. A lot of these patients are mostly treated with systemic anticoagulation and then repeat imaging. Through all the places I've trained at, every center seems to have a different protocol for how this gets done. But the most common baseline is anticoagulation and then repeating imaging about 6 to 8 weeks to see where it's at. Thoracic injuries. The biggest things to focus on when it comes to thoracic injuries, obviously they tend to be extremely devastating because you have some really major vessels there. But you really have to focus on if there's a concern for a patient having thoracic vascular trauma is the incision that you make makes all the difference in getting access to the vessels, right versus left, posterior versus anterior lateral thoracotomies, making the clavicle incisions. These are all very important. But if you don't know what to do, and performing an anterior lateral thoracotomy usually can at least help you identify some part of the injury. So quick overview of choices of incisions. So median stenotomy, you do that for aortic, ascending aortic injuries, for the proximal innominate artery, for the proximal right subclavian artery, for the innominate vein, for the proximal left common carotid. You do a left thoracotomy for left subclavian artery injury and descending aorta. Mid-clavicular injury is usually done for subclavian artery injury, and you can do that for subclavian too. So management of some thoracic injuries. So when you have pulmonary highlight injuries, these patients are bleeding like crazy. Those are the ones that fill the chest tube pretty quickly. Mortality is pretty high with these patients. The most common ways to manage them is just stapling across the lungs and living to fight another day. Blunt thoracic aortic injuries. Majority of patients that have significant injuries usually are dead on the scene, so you don't deal with that. The most common injuries in those patients are injuries to the proximal descending aorta. Have associated symptoms. It's rare for these patients to only have an aortic injury. So you always have to also identify and remember to manage the other pathologies such as head injuries, rib fractures, contusions, and obviously orthopedic injuries. With blunt aortic injuries, the mechanism is usually sudden deceleration. So motor vehicle accidents, someone is going at 70 miles an hour, suddenly stop, and it's that sudden deceleration that causes the tear in the aorta. A contained injury is almost never an emergency, which seems counterintuitive, because if you get a CAT scan in a patient that shows up with an injury to the aorta, the immediate reflex is, we need to fix this right now. But if it's a contained injury, you can actually wait on it. So if you have a patient that comes in, for example, with a contained aortic injury and an injury in the abdomen or the extremities, those actually tend to take precedence over the aorta, which again is counterintuitive when you think about it, because everyone has such incredible fear of the aorta. And so what you focus on for imaging is, you can get a simple chest x-ray. We can tell you a lot about what's going on in the chest. So if you have a patient who comes in with a trauma, you get a chest x-ray, and there's any kind of concern for thoracic injury, you're looking at widening mediastinum, blunt of the aortic knob, deviation of the left mainstem bronchus, obliteration of the aortopulmonary window. So this is a good picture to give you an idea of patients that raise concern for thoracic injuries. So traditional therapies has always been prompt operative repair for the patients with the blunt aortic injuries, but you can also manage this patient not operatively. Now, there's a lot of disagreement about that. So the older surgeons tend to prefer immediate operative intervention. Estimated risk of free rupture is about 1% per hour. Most important thing for this patient is to control the blood pressure and reduce afterload. Endovascular repair. Like I said multiple times, a lot of debate about it. The biggest problems with open repair has pretty significant mortality and increased risk of paraplegia, as you can see based on this slide compared to endovascular repair. The problems with endovascular repair obviously is that you have to think about the size of the grafts you're going to use and the angulation of the aorta, because sometimes the grafts that are available does not match the anatomy that you're dealing with. And then we'll move down to the abdominal vascular injury, definitive versus damage control, like I talked about. A lot of abdominal vascular injuries are managed with initially damage control, because these patients come in extremis and you're just trying to stabilize them initially. Easiest way to deal with patients who are rapidly exsanguinating from abdominal injury is to clamp on the superciliac aorta. These are one of the most common maneuvers as general trauma surgeons that we use to get access to retroperitoneal vessels. which are very commonly responsible for rapid exsanguination in the abdomen. So we call it the Maddox maneuver, the Coker maneuver, the Cattell-Brasch maneuver. Maddox maneuver is pretty much evisceration from the left. So you lift up the left colon, the sigmoid, to allow you access into the left retroperitoneal area. Good for aortic exposure. Coker is the exact opposite. You lift up the right side, good for exposure of the IVC and SMA. Cattell-Brasch is a little more involved, but you can use it for controlling mesenteric injuries in the abdomen. This is just a picture of retroperitoneal vasculature that we think about. So it's all divided into 3 zones. You have zone 1, zone 2, and zone 3. Zone 1 is obviously more central, zone 2 is more lateral, and zone 3 is more distal. Caudal, what's that caudal? So with zone 1 injuries, obviously, as you can see from the pictures, the biggest concerns are the big vessels like the aorta and IVC. When you have a zone 1 injury, blunt or penetrating injury, it mandates exploration. So you must always explore a zone 1 injury. Zone 2, if it's a blunt injury and it's a non-expanding hematoma, you can actually observe it. But if it's an expanding hematoma, then you must explore it. So zone 1 is mandatory no matter what. Zone 2, penetrating versus blunt, you can change your management style. Peritoneal or retrohepatic injuries. These are the scariest injuries for general surgeon because this is usually injury to the inferior vena cava, inferior vena cava, just behind the liver, extremely difficult to control, extremely high mortality. If it's possible in any way, you can do a arteriocaval shunt, which is you connect the right atrium to the inferior vena cava, requires someone with extensive experience. And usually if you're at any time thinking of this repair of this shunt, you're in a pretty bad place. Or I guess the patient is in a pretty bad place and the mortality is extremely high. Peripheral vascular trauma. We actually see this more often than the other traumas that we talk about. Most important thing is assessing the neurologic status of the extremity. So you're checking for motor function, you're checking for sensory function, and you're checking for compartment syndrome. If a patient has ischemia to the peripheral for more than 6 hours, it is extremely unlikely that you will be able to salvage that extremity. You can use a handheld Doppler to check for signals, and always remember that the presence of signals with a Doppler does not actually negate a vascular injury. When it comes to extremity injuries, popliteal injuries are the most common reasons for inability to salvage the limb, and this is usually commonly seen with posterior dislocation of the knee. The brachial artery is the most common injury in general. Roll for arteriogram. Obviously, again, do not use in actively bleeding patients because obviously it's pretty apparent to see where the bleeding is coming from. Helpful to identify areas of injury when you're thinking of your surgical plan. So a patient is stable, you're trying to game out what you're going to do in the operating room. You can do an arteriography to figure out what to do. Usually you repair the bony injuries first because most of this always come with the orthopedic injury. If the patient is unstable, you can do a temporary shunt. And then you allow the orthopedic surgeon to come in, fix the orthopedic injury, and then you go back in and actually do a definitive repair if possible. Small arteries of the arms and actually the leg of the below the knees cannot be saved with a graft. Typically, usually you either have to ligate or you repair definitively. Most patients who come in after an extended period of time with a peripheral vascular injury will require fasciotomy. They're a little more difficult to diagnose. I tend to do a prophylactic fasciotomy in all my trauma patients that have significant peripheral vascular trauma. So fasciotomy. The anterior and lateral compartments are usually approached through a lateral longitudinal injury following the anterior margin of the fibula. The superficial and deep posterior compartments are decompressed through a medial incision. One of the most common reasons surgeons get sued is actually an incomplete fasciotomy, which means that you actually start the decompression and you don't make a complete incision. So the patient still ends up with ischemia and loss of limb. So I tend to make mine very generous from the top to the bottom because you have nothing to lose. So brief overview or brief conclusion is for vascular trauma, no matter what the injury is, always focus on the ABCs first: airway, breathing, and circulation, before you actually turn to the actual etiology of the trauma. And then if it's a vascular injury, you focus on compression and control of hemorrhage. If there is significant hemorrhage, you obviously take the patient to the OR immediately for control. If the patient is stable, you can get imaging to help you identify where the injury is and help you with surgical intervention. It's always prudent to follow the patient with follow-up imaging 6 to 8 weeks after the initial insult. And that concludes my presentation for today. If anyone has any questions or concerns, I'll be happy to address them.
Thank you, Doctor. Nice job. Any questions from the audience before she goes? So in Nigeria or some other parts of the world where we don't have, say, isolated, difficult, poor area, don't have access to the imaging techniques that you like, how would you approach that?
There's a couple of things there's a couple of ways you can approach it. You can say, let's observe the patient and see what happens. If there's no access to imaging and you're concerned, I would say go straight to the operating room. I tend to be more on the aggressive side, and I tend to say operative intervention actually tends to be conservative, tends to be counterintuitive. But if you don't have any imaging that can give you a good idea of what's going on, then the best thing to do would probably actually go in there and actually assess the anatomy on your by yourself.
Dr. Felix Elijah from New York has a question. Go ahead, Felix.
Yeah, thank you so much, Doc, for your presentation. It was very enlightening. I have a couple of questions to ask. In your experience, probably if you have seen a patient with aortic trauma to the descending aorta, I'm just concerned about what's your concern about cross-clamping and with respect to the artery of Adam's quaid, in order not to consider this spinal cord supply. Well, what's your consideration given the scare of exsanguination and all of that? So what do you do about that? And the second one, okay, go ahead.
I was going to answer that quickly. So usually, if I'm cross-clamping the aorta, there is immediate concern for immediate exsanguination. And at that time, the primary focus is just on saving the life. And after that, obviously, when you cross-clamp, it comes with complications that come down the road. But it's one of those things where we'll fix the complications when we get there. For this moment, I'm going to primarily focus on trying to save the life. And so we've done some, over here, they develop like what they call the Reboa, which is an endovascular way of cross-clamping, because you stick a balloon up different zones and you completely occlude the aorta. And I've had patients who've lost limbs because of that. But, like there's a famous saying that says life over limbs. If we can save the life, then we'll deal with the loss of limb. We've also had patients who've gone into renal failure due to, extended cross-clamping. Sometimes what we also tend to do is we release the clamp. So usually when we clamp the aorta, we immediately set a timer. And usually it's the anesthesia team that sets the timer. And they will tell you 10 minutes in, cross-clamp 10 minutes in. And there's sometimes we actually release the clamp for a little bit to allow for a little bit of reperfusion, clamp again, and then continue the repair.
Yeah, thank you for that. The second question I have is just about abdominal compartment syndrome with respect to vascular compromise. How do you have the high index of suspicion to know that this might be maybe a reduced volume or reduced blood supply as against abdominal compartment syndrome in itself? Because I've had that experience. We thought this patient was having reduced blood, where you kept giving fluid, and then before we know it, we discovered that very late. Yes. So in a resource poor setting, how do you suggest that we can really identify that early in order for us to, care for the patient optimally?
That actually is a very good question, because a lot of the symptoms that you have with abdominal compartment syndrome can be symptoms you also have because of the trauma itself. So you're trying to figure out, is it the trauma? Is it because the patient is in extremis? Is that why we're having decreased urine outputs? Why you're having difficulty, like, for example, ventilated patient on the ventilator? The most important thing for me is when most of the time when you have a patient that comes with significant vascular injury, it is extremely rare for me to close the patient on initial presentation. So usually the patients are left open. So we just leave a sterile drape over them, but that doesn't mean the patient cannot have abdominal compartment syndrome. So for me, I'm a little bit, lucky in the fact that I'm also an intensivist. So there are lots of signs from an ICU perspective that point towards abdominal compartment syndrome separate from the trauma. So a lot of times you can feel the really, really tense abdomen, regardless of whether the patient has been closed definitively or whether the patient is still open. The abdomen gets really tense. The second, obviously, is in a resource poor area. It is still possible to actually use a pressure to check the what they call the Foley catheter pressure, which will give you the abdominal compartment pressure. And in the worst case scenario, right, you're not really sure what's going on, open the patient up. You have nothing to lose by opening the patient up and taking the pressure off the abdomen. Again, it's more of focusing on ABC. So if the patient is in the ICU, for example, on the ventilator, you're not really sure if it's abdominal compartment pressure that is causing the problem, or if they're unstable because of bleeding, I just open the patient up. Because if you open the patient up, the symptoms get better, you have an answer, right? If you open the patient up, the symptoms are still the same, then you know that that's actually what's driving, then you know that it's the trauma that is driving the pathology and not increased compartment pressure. One of the things to look up for in the ventilator, if a patient is having worsening, more difficulty ventilating the patient, all of a sudden, or gradually, typically that points to compartment syndrome. So all of a sudden the patient cannot take deep breaths no matter what they're doing, their belly is getting bigger and bigger. For me, that's almost a definitive for abdominal compartment syndrome.
Yeah, thank you so much. Thank you.
No problem.
Very good. Thank you, Dr. Ola. I appreciate your help in talking to us today on a very interesting topic. We appreciate you so much. Thank you so much.
Thank you all.
So our next speaker will be Dr. Gregory Lynch from Pennsylvania. He will be talking to us today on percutaneous AVF creation. Dr. Lynch is an endovascular vascular surgeon. Thank you, Dr. Lynch.
Thank you, Harvard. Okay, I would like to start. Can you hear me?
Yes.
Okay, so this is just a quick presentation, an overview, if you will, of the procedure, and then we'll go from there. It's an ultrasound guided procedure. We're looking at the ultrasound of the upper extremity. Oh.
Here's my needle, straight down, boom, and try to keep the needle tip in the center of your field, okay?
That's the cephalic vein.
And then I'm going to slowly move my needle down as I move my ultrasound down towards his wrist. If we're talking millimeter by millimeter, you're going to follow your needle down. Let me just take a look where I'm going, just to make sure I'm going the right way. Again, follow my needle, move the ultrasound, follow the needle in the center of the vessel. Okay, and then I look ahead to see where I'm going, so I know where I'm going. About to go into the artery. I want to make sure I'm keeping my needle in the right angle, and I'm about to puncture right through. Okay, I'm going to push it, and it goes right in. Keep the needle tip up. I'm actually pushing down on the needle because I want it to go up, not down. And I feel that there is blood flow here, arterial flow. Perfect. No heparin because he's on Eliquis already. Thank you.
That's a radial artery
Okay,
sheath.
now we're going to change the wire out.
6 French slender sheath.
Direction. So that's something you can see when you look at the device. So you should be catching pretty soon.
The device is a 5
right
French.
around here. Yep, I feel some resistance here. Perfect. Okay, so that's my transition zone. Next, it's a little bit awkward, so I'm going to stand up. I don't know if anyone else ever stands up. I'm going to hold my grip exactly the way I want it to. And what I'm going to do is close the device, release it a little bit forward, tension, and you can see me closing the device. And okay, you see the air bubbles right there in the transition zone, right near my arrow. Okay, I'm not putting any pressure on this catheter, very neutral. Now it's cooling, that low sound. And as it goes back to the high pitch, I'm going to pull back ever so gently. Okay, turn it off. Okay, so I already have a fistula there. So we have almost don't need a balloon, but we're going to do it. There's the waist. What is it? This. Okay, and now we're going to freeze. And we're going to measure the diameter of the brachial artery. We have 810 mLs per minute.
Okay, so that was a brief outline of the procedure. Why do we need this procedure? We know as vascular surgeons that the patients that we deal with catheters and grafts can become our most frustrating exercise and intervention because of their repeated problems. So we knew from back in the 90s that fistula was the way to go. But most recent studies, even up to 2018, have demonstrated that up to 20 to 60% of fistulas are thrombosed in 1 year. So that, as a result, we now look for better ways to do the same procedure. What we have found by starting this at my hospital is that patients are more open to percutaneous procedures than are traditional surgical procedures. I guess a lesson learned from laparoscopic surgery. And as a result, we're seeing more patients coming to us for chronic kidney disease stage 4 to have a fistula placed in order to avoid catheters and graft procedures. Let me just see if, okay. So the subtle portions of the technique are that the management of that needle is definitely a learned technique and would take a lot of practice using the ultrasound as well in cooperation with models that industry have available. But it is quickly adapted. And the basic technique is getting through the cephalic vein, passing through a perforator vein, and then into the proximal radial artery. Now, to allow your venous distension to make the procedure easier, we always put a tourniquet above the cephalic vein where we're working. And I also inject what we call a cocktail, heparin, nitro, and verapamil in the hand of the ipsilateral limb to further dilate the venous structures. And I find both those procedures help us cannulate the vein and then proceed through the vein, again, because it's much more dilated. The other thing that you have to be aware of is the cephalic vein in this area has probably been punctured many hundreds of times for venipuncture access, and as a result, there's always some scar tissue in there, and that has to be negotiated. But other than that, we find the procedure is very helpful to our patients. We initially looked at our last 18 months of procedures. 33 procedures were performed. Success was obtained in 95%. That is, we were able to establish the fistula. Now, we don't consider poor development of a fistula a failure. It had occurred in approximately 4 cases where we just converted the fistula either to a open brachiocephalic fistula or a brachiobasilic transposition fistula. So every patient that we initiated the procedure on did go on to have a functioning AV fistula. See if I covered everything. The mapping involves, this is an ultrasound guided procedure. So you do need ultrasound. I do find that when I get my ultrasound technicians involved, not only in the lab, but in the operating room, it has improved my overall studies. And as a result, we're bringing people to the lab or to the operating room who are ready for a procedure, and we can pretty much guarantee success. There's a buy-in. For the most part, you'll find your ultrasound techs will be interested to a point, and then they start weeding themselves out. Those interested will want to come to the operating room, and those not will stay in the lab, and that's fine. But overall, I found it has increased the interest in the patient requiring dialysis access, which is good for everyone. The initial punctures of these fistulas, I do recommend we do under ultrasound guidance. The Medtronics Corporation, which has bought out this company noted on the slide, the Avenue Company, has stepped up their post-procedure surveillance and help with patients in the dialysis centers. So very important that you initiate your dialysis under ultrasound guidance with these procedures. The fistula itself, while a good bruit and thrill is noted, the thrill is distinctly different than what we note after a brachiocephalic or radiocephalic fistula. And it's more of a soft thrill. The thought is that that is due to the increased venous outflow. All the branches that we don't tie off distribute the flow. And it's thought that that combined with not mobilizing the vein and therefore not causing twisting of the vein prevents neo-intimal hyperplasia and a possible fistula failure. So at many levels, this is a good procedure. And I think as time goes on, we can only make it better. Thank you.
Thank you, Dr. Lynch. Any questions on the audience? Percutaneous creation of the fistula, which is helpful for dialysis patients if you have a good number of dialysis patients. A couple of questions for you here. Okay, Dr. Sanusi has a question for you.
Thank you, Dr. Lynch. I'm not sure if I missed it, but is there a particular size and cephalic vein you measure by ultrasound before initiating this procedure. I know you inject the cocktail of verapamil, nitrates, and heparin. But is there a sign of cephalic vein matter before you start the procedure at all?
Your question was the sizing of the veins?
Yeah, is there a size limit to the cephalic vein or a basilic vein that you're using for successful implementation of this procedure?
Yes. So the cephalic, anything greater than 2 millimeters, but more important is the perforator vein that you follow down towards the proximal radial artery. That needs to be 2 millimeters. The proximal radial artery needs to be 2 millimeters. And the distance from the proximal radial artery to the perforator vein needs to be less than 15 millimeters. So that criteria has to be met in order to proceed with this procedure.
Any other questions?
Okay. Thank you, Dr. Lynch, for the presentation.
Thank you.
My question is, I don't know for how long you've been doing this patient follow-up as compared to the conventional non-endovascular fistula. How long have you had to follow them up, and how the vascular fistula last longer than the traditional fistulas?
So during the time we looked at our 33 percutaneous fistulas, we also looked at 16 open surgical fistulas. We did not include any grafts we did. We just looked at fistulas, either surgical or endovascular. And we found that basically the development, the timeline was similar in terms of cannulation time. I'm trying to think of what else did we notice. It was more that the patients came seeking us out for a percutaneous procedure, and our biggest interest was supplying fistulas as opposed to any other access, and we found that was achievable. Now, in terms of long term, I don't have any data for you there. Time will tell. We've just looked at 18 months. We were very happy that it was, again, an ultrasound procedure, avoided radiation, and minimized manipulation of the vessels. And again, patients were quite happy with it as well.
Thank you very much. I appreciate it, Dr. Lynch. Thank you so much for joining us for the conference today.
Thank you.
Thank you. Next speaker would be Dr. Zyko. He's coming to us from Virginia, USA. He'll be talking to us today on the TCAR procedure, which is the transcarotid artery revascularization technique of surgery. This is up and coming compared to traditional carotid endarterectomy. So he'll give us insight into his experience and the benefits of TCAR. Dr. Zyko.
Hello, how's it going?
Thank you.
Just trying to make sure I can pull this up quick. I don't know what happened here. Can you guys see my screen or not?
No, I see your picture, but nothing yet on the screen on your presentation.
Is that, you still can't see that?
Not yet. I see your hands and face.
Thank you. Where would it be under for share screen?
Dr. Lynch, your screen is still shared.
Yeah, Dr. Lynch has to take. Once Dr. Lynch takes the screen off, I think you will probably show.
Is there any way I can go over his or not?
Dr. Lynch, you can disconnect, right? You can get off and I'll take care of it. Yeah, do you have any help for them?
Yep. Dr. Lynch, can you hear us? If you could just press that button beside the mic where it's a square, that'll say X so you can stop sharing. Yes, thank you. And then, is that your screen, Dr. Zeichel?
No. Where do I get? How do I pull
Dr.
mine in?
Lynch re-shared his screen. If you could unshare your screen, please. Thank you.
That's it.
And then Dr. Zeichel, you're now able to share your screen.
It says I'm. How do I share it through my thing? I guess. What button do I push?
Right beside the mic button is a square with an arrow. Once you click
It says
that,
up. Yeah.
yeah, that one, and it'll prompt you to share your screen.
Oh, no. Shoot. It says screen share, but then you still can't see it, right?
No, then you have to click share. So you'll click desktop and share.
Hello.
It doesn't give me an option to show device. No. Because I click it and it just says close share tray, but nothing pops up to like bring it up.
Oh yeah, so when you click it and it opens the share tray, then you click desktop window right under, and then you click, and then you click your entire screen. You click that, and
It doesn't say desktop window when I do click that button. That's the only thing that's weird. Let's see what I could.
Able to see screen. If you don't see desktop, you will see screen. Click on screen and share.
Okay. I'm even trying to do like a right click. As I click open screen, it just goes to a blank screen for some reason below. Let's see. Shoot. Turn on Mac screen share on.
While you're working that out, let's just go ahead and get Dr. Texas in, and we'll come back to you, Dr. Stagel. And Dr. Yati can help you work that process out. So let me get Dr. Dr.Ourania Preventer, and we'll come back to you. Get right. So you have to get it. So we'll come back to you. Okay. So in the meantime, let me kindly introduce. I can't introduce Dr. Ourania Preventer. She is a cardiothoracic surgeon from Texas Baylor University. She is the current president of the International Society of Endovascular Specialists. She's been a great proponent of a chapter here in Africa, and would like her to give us a few words today. And she also has a talk prepared for us too. Rania, thank you for coming on. I appreciate you. I know you're quite busy, so thank you for making the time to speak to us. Thank you.
Can you hear me?
Yes.
Okay. It is really a great honor to present today, and I think Herbert have done an absolutely outstanding job of putting this chapter together and all the talks and the speakers. So thank you. It is a great privilege, and I hope the next year actually to be able to be there in person. And again, I would like to congratulate Herbert for doing this really outstanding job, because it's not easy. And thank you all of you for being there. And I'm very actually glad if you'll be able to join our chapter as well, and the chapter that Dr. Oye is leading in Africa. Thank you. Herbert, thank you so, so much.
Thank you. Thank you, Dr. Ourania.
I'd like to thank Dr. Oye and the organizing committee for this kind invitation. It's really a great privilege to present again to this great conference for Endovascular Solutions for Africa. I'm Eric Evans, I'm the president of the International Society for Endovascular Specialists, and it's actually a tremendous pleasure to present today in this conference. We established the Africa chapter of the ISCVS Society last year, and Dr. Oye have done a tremendous work of establishing the chapter and putting this conference together. So my talk is for acute and chronic type B aortic dissection, the different treatment options. This is my disclosures. Now, this is from epidemiology from a population-based study from Canada, when they looked for the patients who had dissection aneurysms. And they found that among the patients with the dissections, the majority one, when they had type A aortic dissection, 38%, this is 61% that they had a type B dissection. So the majority of the patients presented with a type B dissection, which actually the dissection involves the distal thoracoabdominal aorta. This is a classic representation. We can see when we talk about type A dissection, we mean dissection of the ascending aorta or anything that involves the ascending and the main thoracoabdominal. And then for a type B dissection, anything that involves distal to the anomaly of the artery and involves the main thoracoabdominal, but not the ascending of the aorta. This is regarding the different is an evolution of the classification that we throw out over the years. And you can see that the latest classification is from the reported on the Journal of Vascular Surgery in 2020, and where aortic dissection, if the entry tear is in zone 1, that means distal to the anominate or beyond, this is classified as a type B aortic dissection. You can see here, this is like a type A aortic dissection where the aorta is very fragile. This is an acute situation emergently where the patient needs to go on cardiopulmonary bypass, undergo medial sternotomy, and then repair of the ascending of the aorta. So for the proximal dissection, this is an absolute indication for surgery because you can have tamponel, you can have acute aortic insufficiency or coronary malperfusion. With regards to the distal dissection, this really is an absolute indication for surgery. The type that we have to operate on is if there are what we call complications. That means if there is any distal malperfusion with visceral malperfusion or leg malperfusion. With regards to the acuity, the classic, the traditional nomenclature was that acute dissection is anything less than 2 weeks, subacute something between 2 weeks to 3 months, and more than 3 months is a chronic MOD dissection. But of course, the subacute definition will vary, and with regards to the and why is that? This is, we can see actually the definition from the IRAD data. IRAD is the International Registry for Acute Aortic Dissection that was established in 1996. Multiple centers currently are involved, including in Europe as well as in the United States and around the world, with more than 6,000 active cases. And we can see, according to the IRAD registry, anything that is actually early on within the first 24 hours, this is considered to be hyperacute dissection, and the acute is within a week. So you can see that the subacute consider it everything after a week to 30 days. We compare with the traditional nomenclature, where subacute is after 15 days to up to 3 months. This is important when we look actually the literature. With regard to this aortic dissection, you can see from early on the JAMA paper that 15% of the patients do not survive. And when this registry was updated for the 17 years experience, 15 years later, you can see that this the survival didn't really change a lot. From 15% went down to 11%. So we have some slight improvement, but not really a significant MOD improvement. So 11% still do not survive, and that was with all the cases that they have for the IRAD registry. So with regards to distal aortic dissection, we have the uncomplicated cases. So the complicated cases, when we have the uncomplicated, a lot of times non-operative management is enough with blood pressure management. And the question here is, do we need to put a stent versus the complicated lesions where operative management with or without a stent is the way that is the current treatment. And in today's day, stent is the most common operative management for the complicated cases. You can see when we see the natural history, that was a few years ago in the General Vascular Surgery, of the patients who managed medically with acute AV aortic dissection, and with 30% came to a late intervention within 5 years after the initial presentation. These patients, we can see that their survival was actually improved for the patients who underwent some type of surgical intervention, in contrast with the ones who treated with medical therapy. With regards to the recommendation that was from the early on in 2015, for the uncomplicated dissection, that means the ones that they don't have any malperfusion, that was a class 2A indication that TIVR maybe should be considered. And later on in 2017, for the uncomplicated against AV dissection, the endografting may be considered selectively, and that was a 2B recommendation. With regards to the complicated one, that becomes a little more easier, because in this case, thoracic endografting should be the first line of intervention. In case that there is a malperfusion, then endovascular fenestration should be considered. This is from the recent report, both in thoracic surgery and the General Thoracic and Endovascular Surgery, from both societies, the Society of Thoracic Surgeons and the American Association of Thoracic and Surgery, regarding the guidelines regarding the management. So for the complicated one, endovascular therapy, TIVR, is actually class 1 level of evidence B recommendation. And with regards to the uncomplicated dissection, this is a class of recommendation and will be 2B. With regards to the chronic dissection, we can see here if there is adequate anatomy that is suitable with the proximal and distal landing zones, then TIVR is reasonable, and this is a 2A recommendation. These are the various studies with regards to dissection. The one study that was, and is actually the only randomized study for uncomplicated idea of the dissection, that's the ADSORT study, where they have best medical therapy and patients who treat with the best medical therapy as well as with the stent graft. One thing to consider, and always we have to know that the difference is that when we talk about acute dissection versus a chronic, we can see the flap on the acute dissection is very friable and very fragile, compared with the chronic dissection where the flap is pretty thick. And that's why the timing is actually very important. More early on, the stent can be a little more effective. When we talk about the fundamental principles for the intervention and what is the purpose of the TIVR, the main reason for the aortic dissection, the TIVR, is to relieve the malperfusion and to avoid aortic expansion. The idea is also technically to cover the primary entry tear and any other major communications. So we do what we call the endo-exclusion. We divert the blood flow into the true lumen and we dissolve the true lumen collapse. And as I mentioned before, the timing is actually important. Early on, the flap is much more fragile and friable, and the aortic remodeling early on is actually, they have higher chances for aortic remodeling to happen versus when we have the chronic dissection, where the aortic remodeling increases over time. And maybe the TIVR is not as effective in the chronic phases as is actually on the acute phase. And this is just a few tips and tricks for the endovascular exclusion for when we do the acute type B aortic dissection. That was published in the Annals of Cardiothoracic and Surgery, where I had the honor to be the guest and the editor. So after we establish femoral and access, we can do this with a percutaneous and access or by exposing the femoral artery. On the dissection, we always like to use intravascular ultrasound to verify that we are flow out inside the true lumen. Also with the intravascular ultrasound, we don't necessarily need to keep contrast, which actually is particularly important for patients with renal issues. We can see here with the ultrasound as we go down. We saw the anomaly, then the carotid, and then the subclavian. Here we can see the dissection and when we flap as we're going down with the intravascular with the ultrasound. We can see how mobile is this flap and how compressed is actually the true lumen. And of course, as we go down, you can see over here that was the celiac, the SMA, and that was the renal vein there, and the renal artery right and left. And so as we're advancing the wire sometimes can go in and out of the true lumen. So we have to be aware of that. And then over the soft wire, we advance the catheter, and then the exchange we put the extra stiff Landicus wire and all the way into the ascending the aorta. The question is, after we deploy the stents, how long the stent is to be, and how after we cover the primary tear, if we need to cover all the way up to the celiac and the access. And that really depends. It is our practice most of the time to cover a little bit above the celiac and the axis. The thought process here is that we have to make sure that and that it's, we think about the spinal and the cord. In these cases, it would have to cover the entire descending thoracic and the aorta with more than 10 or 15 centimeters. Then we prefer to put cerebrospinal fluid drainage in these patients to protect the spinal cord. Because as you can see here for this schematic representation, after we place the endovascular stent graft, most of the intercostal arteries are actually covered. So once we have deployed the stents, one of the ways also to avoid spinal cord ischemia and protect the spinal cord, in addition to the cerebrospinal fluid drainage, is to maintain high blood pressure with a mean pressure of the 80 to 90 millimeter of mercury to reduce the risk for spinal cord ischemia. Another thing that we have used lately is a gene dissection of the vascular stent graft. This is we use it when the true lumen distal to the celiac and the axis and across the visceral segment is very compressed, so there is a radiologic malperfusion or there is a clinical malperfusion. And in these cases, we use a dissection of the stent across the visceral and the segment to expand the true lumen. So in general, our approach is that for the acute type B or type 3 aortic dissections, we prefer the TVAR if there are any signs of malperfusion. And if there's no clinical malperfusion, then we do, depending on the imaging, sometimes we wait a few days. And if the patient continues to have back pain or very high blood pressure, we proceed with the TVAR. In case that the ascending aorta is more than 4 centimeters, we have to be extremely careful to avoid retrograde and with dissection, and of course, wire catheter knowledge and minimize manipulation is very important. With regard to the chronic dissection, how to find the success? The success is really dependent on the thromboexclusion of the fast lumen. The fast lumen perfusion can result in aortic expansion of up to 4 millimeters a year. Usually what happens with the dissection after we put a stent graft is that the lower part of the descending thoracic aorta, the one that is not covered by the stent graft, is still, as well as the abdominal portion, is still patent. And we can see here from the circulation paper that this patency and the presence of the blood flow into the false lumen is the most important risk factor for the aortic enlargement. It's very important as we do the chronic dissections to have the right arm to be ready and to use an access as an access embolic in case we cannot get into the true lumen from the femoral artery. So we use the right brachial artery as an access site to place the wire through the true lumen all the way and snare it to the femoral artery. So can have the wire. This is one of our cases, a young patient that came with this dissecting the aneurysm, and that was we excluded, and also we used a balloon to fracture the septum because the septum is pretty big in cases of the dissection. That was also very well evaluated by the Cleveland Clinic. The authors, Dr.Sarah and Dr. Benson, where they published extensively regarding the fracture in the septum with the balloon. All these are like different procedures of the pulse movement, points, iliac plugs, lateral plugs that they have used in conjunction with a T-bar for exclusion of the pulse and the lumen. Long-term follow-up is very important for these elderly patients, especially because they all actually can, over the time, can really expand or the pulse of the lumen. This is a patient who early on you can see how the T-bar actually had very good results in the proximal descending aorta, but then 2 years later you can see the expansion and the pulse lumen. Patient became symptomatic, and then eventually we had to extract the stent and perform a thoracoabdominal aortic aneurysm repair stent 1. Again, I would like to thank you for this kind invitation. I would like to thank Dr. Oye for putting this amazing conference together. I would like to thank also Dr. Oye for being our president for the ISCBS, International Society of Endovascular Specialists, African chapter, and also it's really a tremendous effort to put this great conference together. Thank you, and enjoy the rest of the conference.
Should be on just 1 second. That's kind of nice talk when she comes back.
Thank you. Do you see me?
Well, hear you. Nice talk. Yeah, nice talk.
Let me put the camera back on. Can you see me now?
I can see your beautiful face now. Yeah, thank you, Ronnie. I appreciate it.
Thank you.
Dr. Sanusi wants to give you a question. He's a cardiothoracic surgeon, trained both in Nigeria and the USA. Dr. Sanusi.
Thank you for your talk, Dr. Professor. My question is on the asymptomatic type B, sample type B dissection. Well, how long, you said you wait a few days. Do you wait, is it still in the acute phase or you wait into the subacute phase? And how long do you think it will be into the chronic phase? Can you wait before the dissection flap becomes too thick?
This is, Dr. Sanusi, this is an excellent question, and thank you for being there and helping Dr. Oye with this conference. So what happened is the reason on the acute that there is this tendency to wait for a few days is because of the different adverse events that can happen if you proceed very early on. And we're talking about the cases, the uncomplicated cases, when there's no malperfusion, as you said. So one of the main things that we're really afraid of, as you know, is the retrograde ascenic dissection. If you go like early on and the patient has uncomplicated, and if you manipulate the wires a lot, or if the ascending aorta is close to 4.5 centimeters, studies have shown that these people can be more vulnerable